much more farther, the muscles starts creeping in again. This is not seen in the fixed system because you have actually docked the tube onto the bones, and that's why, and then all the muscles are not coming into the view much more easily. Then is the confusion with the index level. Because it's mobile system, if you are not glued to your screen and your hands are moving without your knowledge, then it may happen that you have gone to a wrong level. And that's why it needs to be confirmed on the fluoroscopic images when you are trying to eat away the bone or go inside and do some other invasive procedures. Unlike in the fixed system, which stays in the place, and once you mark it, then you know that the level is all fixed. Then is the chances of incidental durotomy leading to pseudomeningocele. In the fixed system, particularly at the standard ones, we are actually going paraspinal, and that's why there is a gap between the spinous process and the muscle. Unlike in the muscular dilation method, which is usually employed in the fixed system, and nowadays even in the mobile endoscopic system, where the muscles come back to its place, and henceforth, even if we have a small incidental durotomy, chances of pseudomeningocele is far more lesser in these conditions. So to summarize the advantages of the fixed system, the scope can move in and out without losing the field. It splits the muscle. That's why it causes a minimal paraspinal damage. Direct and focal access to the disease anatomy is achieved, preserving the stability. And nowadays, with the expansile system of the fixed variety, you can have an unconstrained instrument maneuverability. There are multiple levels can be reached with multiple ports, and then option of illumination is there. You can actually put an illumination down in the depth, or you can use a microscope light to give you an illumination from a distance. You can both use endoscope and microscope in these systems, unlike in the mobile system where you only have to use an endoscope. And it has seen an ever increasing use, not only from the lateral, but also anterior, and even intradural procedures can be performed through it. However, there are certain limitations of the fixed system. There are limited vertical or horizontal movements on the spine. Its tubular design restricts the movement. And then instruments have to go in a parallel method. So only one instrument can go in. And that's why it actually creates a limited cone of movement. And it needs abbionated instruments, particularly when you're working with a microscope. The advantages of the mobile system, particularly which uses a air medium, that is the Destando system, is the freedom of movement. You have proper two-hand system. It can cross the midline, and this is the beauty of it. Because of the triangular design, you can actually insert two instruments at the same time, and then you have a feel of it what you are doing. So every time your movement is controlled and under the vision. And because of the 30-degree scope, you have a lot more vision as such. And then you are using the usual straight instrument which you use in microscopic procedures. The limitations, of course, are it's a paraspinal approach, so subparietal dissection leading to chronic pain in the patients after the surgery, and then in some of the patients. And then there's a small port for instrument. So it is not at all good enough when you're putting a graft through it, or you can actually take out all the channels and use the whole sheath to use to put the graft under vision. And then it has a limited bimanual manipulation, and that's why it is not convenient for, particularly when you're operating over the thoracic region where it is very unstable and not good for large lesions. But then this particular limitation is overcome when you're using an hydro environment. So in the air medium, it's a lot of fogging which occurs. So you need to have a suction always inside, but in the hydro environment, that particular fogging is not there. Now, this technology of uniportal as well as UBE are using split muscle technology. So that's why there's no periosteal devascularization of the paraspinal muscles. And then we can have both medial and lateral approaches, and other benefits are there. But only problem with this hydro-based uniportal systems are that it is involving a procedure-specific instrument. So there's a lot of initial cost which is involved. And also it allows only one instrument at one time and does not allow implant placement. So this particular complexity is increasing. However, the non-endo MIS technology is being used even up to in the cases of deformity correction, but endoscopic spine MIS surgeries have to go a long way ahead. So there is always a learning curve, and we have found that the learning curve is much more short in microscopic based tubular methods as compared to endoscopic based mobile system. But then one of these studies which was published in World Neurosurgery 2018 have shown that by 25 to 40 cases, one is good enough in 90% cases to do a basic endoscopic based mobile system uses. So this slide actually shows how the UB has come into picture, combining all the advantages of mobile system and fixed system, as well as removing the restrictions by the use of hydrodissection magnification. Now, there is a principle whenever the water comes in, as you must have seen Dr. Kaushal's video, the moment the water is injected inside the field, it actually gives a very good magnification. So it is just like if you remember your experience in the pathology lab in your MBBS days, whenever we used to put a little bit of oil onto the slide and touch our microscopic lens onto the oil, the whole magnification got much more better. So this magnification is much more improved on the hydro in the environment, and also it clears the field of any dirt. At the same time, I've seen that in the UV technology, the chances of bleeding from the venous side is far more lesser, maybe because the pressure of the fluid is actually compressing the venous sinuses in the epidural spaces. And that's why this particular technology is a lot more better as it seems now. So to conclude, there are pros and cons of either fixed or mobile tubular systems. However, the basic idea which Dr. In the last day presentation we have seen, the objective of the surgery is very important for us to understand, and then we can select these type of different tools. We have to try for maximum intervention with minimal trauma, and mobile system has advantages of capturing larger areas through one port. Our fixed systems provide bimanual dexterity and larger ports for implants. Thank you for your patience listening.
Thank you, Dr. Amit. Any question from the delegate side? Arvidas sir, any comments?
So as a chairman, you started with MISS. And you told that we are not compromising on the goal. So all our surgeries are maximally invasive at the site of the pathology. So MISS is a misnomer now. I completed 20 years in endoscopy. I did my first surgery 23rd September 2002. So we are maximally invasive at the site of the pathology. Only what we are thinking that we are traumatizing the muscle less. Second thing about the 3D. If you have a 3D endoscope, you will get a 3D image just like microscope, and it will be a mobile microscope because you'll not be able to move the microscope. But endoscope with 3D vision, you will be able to move around. Future, it will be 4K with 3D. Now about this air and fluid. I don't understand. I have not understood since last 20 years. When it is a fluid, it is a pure technique. Or when it is a air, it is an assisted technique. It's not correct. The AO also tries to manipulate all these things. I don't believe in that. When it is a fixed tubular retractor, your retractor gets fixed on the lamina. And in between, you use a unipolar cautery to remove the muscle. So basic thing is you have to separate the muscle from the interspinous ligament, both the lamina, cranial and caudal. Retract them nicely, then the trauma will be less. Any comment from the faculty?
Okay, just want to say that what do you think about the full endoscopy or hemi or semi endoscopic?
This is what
classifications.
Who has that nomenclature and how they have defined it? I have still not understood in 20 years.
And that's the same reason why I put this slide here, because I also don't feel comfortable with this definition. But then there's a whole group, and
that's why I started using 3D endoscope. First time I used 3D endoscope was in 2015, Vision Sense. Then I used 3D converter by Mashida, and since October 2017 I am using STOS 3D endoscope. Now no microscopy guy can say me now that there is no depth appreciation.
This is like the scopes evolution. First it was 30 degrees. Then they said we can't see much in the posterior side. We have 70 degrees. And now they wanted to have panoramic vision. So 0 degrees.
No. The basic of endoscopy is the panoramic vision against the microscope.
Yeah, that's true.
I think with 3D coming in, endoscope is now again scoring over microscope, and most of the microscopic guys also trying their hands on now
so this
3D endoscopy. So I think we are evolving.
So this I need to clarify because I'm using 3D endoscope. I have a Carlstroh system with a 3D endoscope latest technology, and I can vouch for you. even though we say that the 3D technology in endoscope is going to be a game changer, that's not always true.
No, no,
Why?
no, that's
Because-
not true. I agree with you.
because the physics have already shown us that the magnification which we get out of a microscope is far more superior than endoscope. So nowhere you can have, even with the 3D technology in endoscope, nowhere you can match a microscope.
You are using
Always-
tip cam.
But then the 3D endoscope, what is happening is, sir, like much more of a digitalization has occurred.
Yeah.
So when you are actually operating with a 3D endoscope under magnification, it actually starts, the images start getting pixelated.
Now,
And
which
that's
3D
what-
endoscope you are using?
Yeah, endoscope.
Which 3D endoscope you are using?
Karlsruhe.
Tip cam.
Yes. So the problem with this, that even with the 4K technology or the 4K screen, the pixels comes and starts.
4K is magnification only of the picture, nothing else.
Yes.
Same camera. When it is a 3D, you can move the endoscope up to the site of pathology. If you are using it for skull base or something like that, you can just go inside that, and then the magnification is super. And with 3D, the periphery of the image is also crystal clear. It is a sharp image. I'll be operating now the second case with 3D. You will be able to see it in here in 2D, but I'll be operating in 3D. So the advantage is you can go down, move around, which is not possible with microscope with any exposure.
What I'm trying to make a point here is that even if you're using a 3D endoscope, try to come closer to the image of interest
Yeah.
rather than sitting at a distance. Why? Because if you stay at a distance, what happens is you start using magnification, and that magnification is not good in endoscope. That's what is I'm trying to.
There is
convey.
no magnification. It is the image. There is no need of focusing or refocusing. The
Dr.
3D
Naidas?
endoscope is always in
Yeah.
focus.
Can we go back to the surgery, please?
Yeah.
Yeah. Thank you, Dr. Amit,
Thank you.
for a wonderful lecture. We appreciate. Yes, Dr. Malcolm, how far you have come? Please. Shamsha?
Hello, Dr. Malcolm. अरे ओटी का वॉल्यूम बढ़ाओ ना थोड़ा. हेलो हेलो शैशव. या ये यहाँ वाला वॉइस वहां नहीं पहुंच रहा है. हेलो.
They want to see it, we show them. Now this is they're coming down on the SCP. Okay.
Hello, operation theater. Can you hear us?
अभी आया. हेलो
Hello.
सर, हमारे साथ भी बातें करो, अकेले अकेले मत करो.
Ah, yeah. Which way I'm missing you? Aja, what is now let me just go through everything. 1 minute. Stop, please firing. Right now, this was the original lighting defect. Okay. Then this is the lamina, the interior lamina, and as we come here, we're coming up onto the spinous process here. Can you see this bone? And this is the original interlaminar window, small interlaminar window which is left. Okay. Big buccal label here. And both the spinous processes are kissing each other up here. There's no gap. There's zero gap between this and this spinous process. This is the interspinous ligament which Hayati wanted to see. Touch, please. No. So this is the interspinous ligament which we are coming upon between two spinous processes. And this is the little tissue in between. Okay, and then now we are going up on the interior lamina again. And then now I'm coming up here onto the lower part of the facet, but it's actually the IAP.
Dr. Malcolm? The virtual talk, the guy is waiting. Can we hear his talk and come back to you?
Yes, please.
Dr. Kochi Sairo?
Yeah, please.
Yeah.
Yes.
Dr. Paras?
I just only oriented you to what we have stripped. That's it.
Yeah, thank you.
Give me yellow, please.
Just give me 5 minutes.
Hello, everybody. My name is Koichi Saida from Tokushima University, Tokushima, Japan. My talk is on endoscopic. Hello, everybody. My name is Koichi Saida from Tokushima University, Tokushima, Japan. My talk is on endoscopic intradiscal surgery for low back pain in professional baseball players. Hello, everybody. My name is Koichi Saida from Tokushima University, Tokushima, Japan. My talk is on endoscopic intradiscal surgery for low back pain in professional baseball players, thermal annuloplasty and disc cleaning. Both of them are using a endoscope. My COI. As a endoscopic intradiscal surgery, today's I talk on discogenic pain and type 1 modic change. As a discogenic pain, there are two very important signs. For example, on MRI, high signal intensity zone. This is high signal intensity zone. And the other one is toxic annular tear. Toxic annular tear is CT discography. Here, this is a tear with pain. We say toxic annular tear. HAZ is proposed by April and Baghdad in 1992. They say HAZ is the pain generator of the discogenic pain. So HAZ is well correlated with positive sign of the discography. So this should be the pain generator. Toxic annular tear is first proposed by Tony Young, my mentor, 2017. During discography, also the tear, he said, painful annular tear or toxic annular tear. I like the term of toxic annular tear. I can see one example. She is 23 years old female, Olympian, Vancouver, skier. Just lower pain, infection after Vancouver Olympic game. It shows high signal intensity zone here. But this is okay, not degenerate, but painful. And I did discography here and the leakage to HIG. So this leakage, this is through the toxic tear. After one injection of lidocaine, the pain subsided. And 3 years after the injection, see here, disc degeneration a little bit, but HIG is subsided. No more back pain anymore. Then she attended Sochi Olympic game. For surgery, Tony Young first proposed the usefulness of the radio pulse thermal annuloplasty for toxic tear plus high signal intensity zone. So I'm doing I'm following his technique. This case is 36, self-defense officer having a discogenic pain due to HIZ. See here, HIZ. I inserted the scope inside the disc. You see here, this is a toxic tear. And ablations performed here. And finally, in the HIZ area, I saw the disc fragment with a new vessels and also bleeding at the area of HIZ. This is a pain generator. The pathology. But the discoscopic findings around HIZ, here, nucleus fragment with new vessels right here and here and here, and also bleeding from here, annulus fibrosis. This is unlike usually annulus fibrosis that doesn't have such vessels. One example is professional baseball player in fielder. See degenerated disc plus 5S high signal intensity zone plus sometimes lidocaine or sometimes steroid, it can be healed. However, if it is not healed, I recommend surgery. Gold standard of the type 1 mode exchange is fusion, but recently I started intradiscal disc cleaning surgery for these inflammatory conditions. Foraminoplastic outside in into the disc space. So type 1 mode exchange cause a lot of scarring in the disc space. So remove it. And disc irrigation of the inflammation. And finally, sometimes new vessels is seen through the end plate and coagulated. This is disc cleaning. This case has a type 1 and type 2 mode exchange, but the important thing is inflammation or bone edema on STIR. I did conservative treatment for 1 year, but nothing changed. See here? So I did the surgery to him, and 4 months later, no more inflammation, no more edema, and also no pain. He started golfing. This is discoscopic findings. You see a lot of bleeding through the end plate, and also interesting, the color of the cartilage changed to yellow discoloration. So those are interesting discoscopic findings of type 1 mode exchange. I checked the initial paper by Professor Modic in 1988. He described that disruption and the fissuring of the end plates and the vascularized fibrous tissue. So after 34 years of this initial report, I proved it using a discoscopic findings. The second case is professional baseball player. He's suffering from lower pain for 3 years, and it is increasing year by year. The visual analog scale of the pain is 8 at his ADL. On STIR, strong inflammation is there. And I did this screening for him, and the BAS is decreasing day by day. And finally, in day 14, he doesn't have a lower pain anymore. And he returned to the game at the following season in 2021, no more back pain, and he spent a very nice season. I did 15 professional baseball players for FED, thermal angioplasty, and disc cleaning. 4 cases was in the pre-season, and 3 cases was in season, and 8 cases are post-season. And 100% cases can return to the original activity at least next season. Among them, 2 was selected as a member of the Samurai Japan and Tokyo Olympic, and they got gold medal. So 2 patients after back surgery received the gold medal. I'm very happy to that. Thank you very much. Hello, everybody. My name is Koichi Sairyo from Tokushima University, Tokushima, Japan.
This is
my
a
talk is
model.
Hello.
Thank you very much.
Dr. Sairo, are you there with us?
Yes, I'm here.
Yeah.
Yes, I have a question for Dr. Saira. Thank you for your excellent lecture. Do you hear me, Dr. Saira?
Yes. Yes. Okay.
I wonder the post-operative patient management. Can you explain a little bit?
Okay. For 1 month, just conditioning, like chest or legs or and just strengthening of the muscles or the back muscles. And after 4 weeks, he started jogging, running a little bit. And 2 months, they return completely. Usually, to the return to the game is around 3 months after surgery. So the connection with the athletic trainer is very important after surgery.
Dr. Sairo,
Yes.
your sport basically is a lot of bending, twisting of the spine, the
Right.
baseball, right?
Yes.
You said about some your famous sports in Japan that requires a lot of bending. So
Right.
when this, what kind of a rest you give for bending when you do this surgery? Do they bend after 1 month or after 2 months or 3 months?
Yeah, actually, 1 month.
4
But,
months.
1
1
month.
month, I see.
But the important thing is motor control exercise. Bending in the thorax, not lumbar spine. Education, just bend thoracic and pelvic. Not so. Lumbar spine is always a neutral position. This is education. So rehabilitation is very important. Thorax and legs to move, and lumbar spine keep it neutral. So this is a motor control rehabilitation.
There are 2 types of bending, as I
Yes.
see. One by standing, and other one you bend the spine lying down, taking your knees to the chest. So which one you start? The gravity bending or against gravity?
Gravity bending is dangerous in 1 month after surgery. So gravity bending 2 months. So
I have another question for you. So, do you have any criteria for the patient selection? Because we know that many of like these cases can heal spontaneously when you limited the movements. Do you have any criteria for case selection?
discogenic pain is like a chronic, usually need a surgery, chronic discogenic pain. But for disc herniation, herniated nucleus pulposus, yeah, it is it disappears. So, but they are professional players. So if they have a herniated mass, we to do a surgery post season because they need to do the sports in the spring. So winter time, I do surgery.
Yeah, Dr. Koichi,
Yes.
I'm Pantavir from Thailand. I would like to ask you about how long that you follow the patient and how many percent have the recurrent or instability after your cleaning procedure.
Okay. For a professional athlete, I'm following them up at the end of the until the retirement, 100 and also 100%. But for recurrence in my series, professional 0%. Maybe post rehabilitation or conditioning with a special trainer is very important. But generally speaking, 10% of the recurrence I have in a normal people or non-athletes. But for this series, there are no recurrence.
And your technique is inside out, right?
No. For yes, basically outside in. Outside foraminoplasty and making a big canvas triangle and go in to avoid exiting nerve root injury.
Okay, understood. And your diameter of your scope is 7 or 8?
7.5 or about 8.
Okay, thank you so much.
One more question.
Okay.
GM yeah, we work together on a few projects. So regarding the L5S1 central region, I think sometimes there's a high iliac crest and it might be a little bit more challenging. You might have to take a bit more superior articular process. Do you have any tips on reaching the central region for L5S1 in high iliac crest? Especially a lot of your athletes are male. So any tips and tricks for that?
Yeah, I usually take a CT scan or MRI and measure the angle. But before I started the foraminoplasty, 5S was very challenging. But after I started the foraminoplasty, even though the iliac height is like a 4-5 disc space, very high, we can perform it. So most important thing is foraminoplasty.
Dr. Kochi Sayaro, Dr. Rohidas here.
Yes.
Yeah. Now these are professional players. They have backache.
Yes.
And you feel that this is a discogenic pain. And you go inside and decompress the disc. Okay. So
yes.
I could understand that if you decompress the disc, the backache will disappear along with the post-operative management. Is that true?
No, not that decompression. It's ablation, thermal annuloplasty for a toxic annular tear and high signal.
So you don't decompress the disc. You don't go inside the disc.
Just a little bit, not much.
Okay.
Yeah, radio pulse ablation for new vessel and new nerves inside of the disc.
And suppose you are going transformally. Suppose there is a central tear, then what to do?
I did 99.9% transforaminal, but only one case, L6S1 case. It was very tough for transforaminal, so I did interlaminar thermal annuloplasty for a central HRG. But usually I do transforaminal.
Excuse me.
Okay.
One more question, please. Can I ask you whether the annuloplasty or nucleoplasty is enough for the discogenic pain, as you would like to ablation of the new nociceptor for pain? Why you are do shaving for the disc? Is the annuloplasty and nucleoplasty is enough or not?
Yeah, I always check the tear during using discography, CT discography, and the tear, and also high signal intensity zone. There are vessel and nerve. If you insert a endoscope inside the disc, you see the bleeding vessels. Vessels also nerves always together because I cannot see the nerve. So usually ablate toxic. So annulus, not a nucleus. Annulus fibrosis. So, but pain generator is annulus, not the nucleus. Is it okay?
Yes. So you depend on thermal ablation more than the shaving.
Thermal radio pulse, thermal annuloplasty for annular tear in the HRZ.
Thank you.
Well, thank you so much. And let me move to the next topics, Professor.
Much.
Hello.
Yeah.
Can we have the next lecture? Dr. Perez?
Dr. Perez.
Rodolfo Perez.
Dr. Perez, Rodolfo Perez, please.
Yeah.
For Mexico, the topic is the biportal approach in the degenerative spine complication and how we solve it. Dr. Perez, please.
Bienvenido.
Thank you, everybody. Thank you, Dr. Malcolm and Third Congress of the Spinal Surgery for inviting me. The topic to we learn in this moment is difficult because everybody here talking about the win, talking about the cases to exit. And we have 8 minutes for my confession to you. Okay, my topic is biportal approaching degenerative spine and complication and how we resolve with that. It's difficult when you don't have a lot of information about the complication in these surgeries. Everybody, I know that I told you, is only talking about the win. But what happened when you use that? That is my patients in my surgeries, in my center. Try to do it all technology in my hands. My anesthesiology, do it with use a vis. In some of the cases, I do it electrostimulation and neuromonitoration transoperatory, and try to do the safe more for me and my patients. I show you one patient for one out of my faults I have. This is the transoperation electromonitoring about the one patient of the 45 years. And everybody knows the electrostimulation and neuromonitoration is more for the motor than the sensitive rods. And you see in the graphic in green, the stimulation before the surgery, in yellow, during the surgery, and in purple, after the surgery. And you can see everything is good. and in the purple line is more up than the other one. That is for great result, no? But this is the value of that surgery. In that surgery, I stayed in the left side, L4R5. I'm sorry. Okay, L4R5. And we are a very good resolver the compression of the flavum ligament more of the left side. I'm very confident in my doctor with my electrophysiology out of my side. And every time I ask, can I do it? Can I do it? You see something in the electrostimulation? No, you can do it. You can do it. That's it. The surgery is done. But everybody here at obsessive compulsive, that is the dura madre. And in this moment of the surgery, I can finish, but I see more flavum ligament, and I say, why not? I need to keep that, no? In this moment of the surgery, I take in a bait, and I see something, don't like it, and I ask for my physiology. Can I do that? Yes, sure. Don't show me nothing. Really sure, because, and I put up, I see that different. Yes, it's possible. And I bite. You see that? Really, I can do it? Yes, you can do it. Really? Really? And I do it. See this. Oh no. Poof. That's it, the root. And I say, why did I do it right now? What happened? That's because I have my electrophysiology, I have everything about it. That's not happened. But I confess more in my electrophysiology than me. This patient, after 4 weeks of the half a rehabilitation, only have a paresthesia. Thanks God, the anterior rod is a motor, no happen nothing. But this is the one first lesson. Never throw in other thing, another body, in other mind. That's you are the surgery. You are the only people to know what happened in this surgery in this moment. You please try to do it. You need to do it for your patient, but you don't throw in other people, because in this moment, in your hands is the life of the patient. The other one for intervention. This male is 55 years old, have a chronic back pain, and have a hernia. I do the liberation of the L2, L3, L3, L4, and L5, L5, S1 have a hernia. And the hernia is easy for biportal approach. You can see the hernia in the shoulder of the L5S1 to the left side. Is very clean, and everybody know what happened is you take the hernia and go out and finish. No, the problem in these cases in particular is I don't return for exploring again for if the patient have more hernia. And in this moment, I take in the hernia and go out. It's easy, it's piece of cake. The surgery is end. But after the surgery, immediately after the surgery, when the patient start to move the leg, say me, oh, I have a pain, an electric shock. Again, really? Yes, what is my fault? I don't return for see if have other hernia, and I take an MRI, and yes, we have more hernia, and this is the second intervention, and a couple of hours after that surgery. That surgery is bajo sedation and local anesthesia, but we have more hernia. What is the second lesion? Please, 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 every time you check, and don't go out. You only go out when you feel 100% sure everything is good. The third and the worst, the dural injury. Everybody here have a dural injury. What is the problem? really what is the treatment in endoscopic surgery. In these cases, I do it at this compression on L4, L5, L3, L4 from one patient of the 80 years. And my fellow taking the hands. In this moment, I give you the liberty of do it and something for learn and start to doing in the first steps in the biportal endoscopic approach. And he do it that and say me, doctor, I say something wrong. And I say, no happen nothing. Let me to give you a message for my wife. And I go for the other part. And my anesthesiologist say with the electrostimulation, Rodolfo, please come back. Please, 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 please. Because the name is Eric. Eric, doing something because change the electrostimulation in the V's and the potentials. Okay, let me to see. What is this, Eric? I don't know, but let me to do that. Oh man. In this moment, I change again. I put my gloves and try to resolve that. What happened in these cases? Or when I have my dural problems. The first is try to return the nerves from the sac. The second is know what is the size of this. Remember, in endoscopic surgery, all see big, but it is small. Okay, after to return that, I put a peridural fat. After that, put a pedicle of the flavum ligament and put a gel foam. And never of the patients have a fistula of the fluid liquid cephalorachid. Obviously, this patient is in bed for a couple of days, have a lot of problems with the headache, but thank God, nothing more past. I don't know what happened with it, but that is the last part. You can see the health gel foam after put the fat, flavum ligament, and gel foam. In my center, right now we have our 480 patients. Of these, 12 have a problem, 13 have a problem. 3 nervous injury. You see the two of these. 2 have a reintervention, and 8 duress injuries. Really is less, is very less comparing with the open surgery, minimal invasive surgery. That's happened, and it's necessary to know what to do in these cases. Conclusion: no procedure is 100% sure. Try to use all the possible tools, but the principal tool is your brain and your hands. And the other, be careful when you are about to finish. In this moment is the more dangerous part of the surgery. That's just how he'll say. Be careful in the last part of the surgery. Be patient. The great advance on endoscopic surgery is that the complication is just that small, and the mole that will resolve for themselves. The others is part of the God. Need to be like a Galapagos lagarde. Need adaptation. Need adaptation from something and change everything about the surgery. You need a plan A, B, and C. Thank you very much. Mexico is welcome for you. Name of my team. Thank you.
Thank you, Dr. Perez. That was a wonderful talk. Any questions for him? Any questions for Dr. Perez? For the first case, you are looking at the nerve root. There is no question. There is no this thing of asking the neuromonitor person. Everything is in front of you. Endoscopy means you are under the vision. You are looking at the root, looking at the dura. So I don't think there is any need to ask the neuromonitor person.
Yeah, but you're in one only appointment in my chart is because have a one problem. Have and right now the legal problem is necessary to do that because if this patient happens something and you know how do you say how show something you know are wrong, you are in very big problems because it's necessary and give you a one more little things in safety for you and your patients. That is only the point. You are agree. I agree with you, Professor. I'm really that's it. It's true, but no, it's absolutely necessary. But it's all too.
For documentation here, we some, okay, we
the
go back.
house,
How many of you in India use for lumbar spine?
in the house, I
Tell
like to
me
know from other
honestly.
countries. No,
Please.
Rohitas, let's
Yeah.
ask others also.
First
Any,
in India and then
all
we'll go outside.
international colleagues, are you doing routinely neuromonitoring for your endoscopic disc cases? How many of you are doing this? And
No.
is it a legal requirement in your country that you
No,
have
no,
to neuromonitor
no,
when you're doing
no.
endoscopic discectomy? Because two cases you have shown, I could see as a surgeon, you know what you're holding when you're asking your other guy that all is well, and the nerve root is pulled out. I mean, it's a see and do surgery. You can tell that guy to shut up. You are not guiding me well. I mean, I could see that when you have pulled that out, as Rohidas has said, that disaster is waiting to happen. Similarly, your training guy, when he was doing, he caused CSF injury. I mean, I could see that he is pulling out the something which is not normal. And I don't know how many in the house are using a neuromonitoring.
And for that, surgeon is responsible, not the neuromonitor person.
Yeah.
So I like Dr. Perez in my country, everyone do discectomy, be microscope. Most of us use neuromonitoring. It's the country's practice. So if everyone else in open or microscopic or tubular do neuromonitoring, you do neuromonitoring. I find it very useful if you were to retract, especially a central large calcified disc, if you will retract your nerve root for probably a bit longer, the neuromonitoring person will be very useful. They can remind you there's some irritation, then you relax. But of course, we don't depend on the neuromonitoring to tell us whether we should take this specific tissue in terms of using kerosene. But I think if you retract too long, or in the cervical case, if you do more than 60 minutes, they will start telling you there will be some changes, and then you got to hurry up, got to speed up. I think that is useful.
Yeah, Dr. Deshpande?
Very nice presentation, sir.
Thank you.
In your presentation videos, I saw that in 3 of those videos, the notch of the scope was at different positions. When I do my biportal surgery, always the notch is placed at the central, whether it is at the 12 o'clock or 6 o'clock, depending on which company scope you're using.
Yeah.
So that changes orientation a little bit. So you think, I mean, it's like operating by looking in a tilted mirror. Because if your instrument is supposed to come down from 3 o'clock position, it doesn't if your notch is at that position. So does that cause any problem? And secondly, the last dural tear that you showed, there was incomplete flavor removal from the lower lamina. So you think that was the reason that manipulation of the nerve root with an incomplete epidural space opening was the reason for dural tear?
Yeah, you're true, and depends of the patient of the orientation of the line mine. And depends on the close of the spaces, and that is depends for me to do it more close from the medial line, or I need to do it more lateral. That's it. That is only for my form of the do the surgery. And the other is you are true. You have depends of the endoscope. You can move for 360 grades, and depends of that you have a 30 grades, 70 grades, 90 grades. That is true, but that's my form to do that.
Okay, last question, Dr. Sharon.
Yeah, see, something which I do is, our patients can't afford that electro monitoring. So what we do is, whenever we are working on that dangerous zone, we place our hand on the bum of the patient. So when we are using that cautery or we are pulling out, even if a minor jump is there, we should stop it.
No, that's a problem. No jumping.
Yeah,
that's the problem, because the best monitoring is my instrument with the hand in the leg, because in the moment when I touch the nerve is jumping. That in these cases in particular, I don't know why. I don't have the answer. the nerve and the leg no move, and that is the problem because the electrophysiology say don't show me nothing. That is the point.
Okay.
Never throw in other your and your hands and your endoscope. That is the point of the doctor.
Everybody likes you so much. They want to ask question. The last question now.
Yeah,
Dr.
David.
Ben.
It's more of a comment because when I first started, and we're very much like little babies, we don't really know what to do, so you kind of overdo things. But I use neuromonitoring, and I found it to be unreliable because if a person had a dysesthesia after surgery, the neuromonitoring was always completely normal. So I just quit. And as the other person commented, there's a significant cost associated with using that.
Okay, can we go back to surgery now, Dr. Malcolm? Thank you very much, Dr. Dalal.
Touch, please. Blue.
Gracias.
So now we are going around the tip of the SAP. Okay. Lot of fibrous tissue over here.
Still loud, please.
The whole purpose is for doing this surgery. This little. Yeah, sure.
Can you increase the sound?
Good morning. Can you hear me, please?
Yeah, now the hall is full
You all are enjoying
watching
our
you.
struggle. And this is. Can you see this, sir? That was what is shining inside.
What is that structure? You are showing the
That
nerve.
is small mouse of the facet joint.
Right.
And this is the SAP. Blue, please. This is the root that is exiting out. So the fat over the root. It's over here. And we have removed the IAP. We have removed the lateral, rattler. I'm just controlling a little bleeding. थोड़ा ब्लू वाड़वा रे बोन वैक्स का थोड़ा we are on the route here, but we are outside the foramen. Okay, and John, the pressure की दिया था जरा 1/160 का.
Hello,
Yeah, Dr.
Malcolm, can you hear us?
Yes. Now we have
Yeah.
one. We're having a little bleeding.
Okay. Once you control that, I will request you to orient us.
Stop you. 1 minute. Can I have a we have removed the rattler. We have removed IAP completely. Okay. The dura is separated. Outside
Can the outside camera be changed and can they show us your hand movements instead of your backs?
Sorry. Dimension look, please. Dimension change karo. Plasma frequency probe. What we are using right now is manufactured by Bonds. 5, 3, 2. The plasma. There are few Lavadava, please. John Howe. John Papers is now the assistant for many years.
Can the cameraman zoom in, please?
So Dr. Malcolm
Thank
is
you.
a ambidextrous person. So he can use both his hands equally well.
I mean, as surgeons, we always talk of right hand, left hand domination, no? बाकी remark करने वाला उसको छोड़ दिया मैंने. Stop, please. 1 minute. Fire blue, please. Now this is the tip of the SAP
Okay.
coming out in the foramen. I'm going around the tip of the SAP. Can you see this?
Yeah.
I'm just above the nerve root. Nerve root is below me. It's bleeding a little bit. Unfortunately, we will be controlling that slowly. Just 1 minute. Touch, please. Blue. Touch. Little bone over here. We need to fracture some bone here. The rattler, all fibrous tissues. So they tend to burn, bleed a little. You can see the root is being pushed away by our probe. Okay.
Have you already removed some part of the bone there?
Yeah, we removed some part of the bone there. Superior reticular wall, which is in our view. We have some bleeding issues from there. So, the yellow mara ikkade. Can I have some bone wax, please? Stop, please. Some bone wax. Now, this is the interlaminar window.
Is the blood pressure higher?
No, not really, but this is all chronic tissue now. Many years chronic tissue. So it tends to bleed a bit. Keeps coming in my view, so I might have to keep counting. It's very critical working. I don't want it. Now what I'm going to do is I'm going to use the diamond tip burr. I'm going to start burring this inner edge, tip of SAP. Some of it we are going to osteotomize also.
Dr. Paras, the other virtual talk is ready.
This is the exiting route which you're seeing here, guys. Okay, it is going outside the SAP, but below the SAP here. Can you see?
Dr. Malcolm, can we have the other virtual talk?
Yeah, please go ahead.
All right, thank you.
My name is Zenito from Japan. Today, I will talk about sacral epirodoscopic laser discectomy technique learned from case studies. Posterior spinal decompression surgery evolved from open laminectomy to the microscope, followed by microendoscopic decompression. Recently, a less invasive method, percutaneous endoscopic laminectomy, was developed. We studied this clinical study in 2013, but in recent, there is next stage. Next stage, 3 mm scope develops in the world, especially in Korea. SCLD kit bend flexibly, usually used adhesion released by anesthesiologists for severe cases against spinal operation. However, in recent, we can use to remove herniation and cure low back pain with ATIZ. Catheter has 2 holes. One is for camera, another one is for razor and forceps. The indication of SCLD is low back pain with HIG or small herniation. This is the technique of SCLD. from the sacral hole and through ventral side of the dura, and insert the camera. We can see the herniation in the dura. And after that, using the balloon and remove the adhesion and making a space. And after that, using the laser, shrinkage herniation. After SCLD catheter inserted, I find herniation and confirm margin of nerve root and herniation using holmium YAG laser, shrinkage, and decompress herniation. And we confirm to make the space during the laser. And after laser, we use forceps and remove herniation piece by piece. Get the piece of herniation like this. And second case, this chest is good indication of SCLD. We had to rely on open surgery to remove of symptomatic discal cyst. Using the laser, break the cyst wall. And we can find the cyst water, like this yellow cyst water. And like a herniation, shrinkage the cyst wall. And decompression, making space. And third case, adhesiolysis post-operative syndrome is also good indication of SCLD. We cannot rely on open surgery to treat this. The clinical data of SCLD in our hospital, we operated 133 cases. All patients had low back pain with or without radiculopathy. The result is significantly improved from post-operative score within 2 weeks and continue 3 months in all parts. The characteristic of SCLD is one is an approach march level. The second one is approach both sides. And third one is confirm reproduction pain during operation. And we improve the camera like this. So nowadays we use the new camera Creo. Conclusion: SCLD is new technique as at least invasion, even enable to day surgery. Approach not only herniation but also low back pain. Now improving more and more. Thank you very much.
Thank you, Dr. Ito. Dr. Ito is not online, so we can't ask him questions. Can we ask Dr. Ajay Krishnan? Is he here? To give his talk on calcified disc PTLD.
I see many masters here, enlightened masters, and this is just a small talk amongst them. I see many masters here, and I just give a small talk, which is an extrapolation of our acquired knowledge to the next level. And to come to that, that is PTLD, that is transforaminal approach for a ventral decompression that is more than a disc. So a calcified lumbar disc stenosis. So what I'm talking about here is, we all know for more settled days, more advanced degenerations, you have spurs which form there with osteocartilaginous components and with the narrow canal which acts as a stenotic there. And there could be instabilities, there could be imbalances, modic changes, Fuhrman grades. These all, many of the advanced grades have been indicated for fusion, which I also do in most of the cases, but I have explored myself to a level of ventral decompression only. Now, to come to this paper, I would. Are we on relay? Yeah. So this paper I would like to call our own Rajshekharan sir's paper is there, and that paper had been a ISLS prize winner, which clearly explained as most of the disc prolapses are actually not a transannular disc prolapse, but they are actually end plate injuries, and there is usually calcified part to it as bone or a end plate injury, and which can in later part heal up and just show us a irregularity or leave it with some osteophytic spurs there. It could be on one or it can be on two sides also. So when this is the picture and it is contributing to a ventral disc, at the same time maybe a stenotic component, long standing cases, patients coming to you with 8 months, 9 months, 12 months of complaints, not a typical disc wherein he's complaining, coming with an acute presentation, but a long-standing case with acute exacerbation. And this is what is there. Like you find a claw osteophyte outside the spine for stabilizing, the same way things are happening inside the spine in the form of inferior end plate spurs, the superior end plate spurs, or both spurs, or at times the entire rim is calcified. So annulus itself can be calcified. And what we are talking about is all leading to a calcified ventral stenosis. And in conventional surgery, what we do is a posterior laminectomy or a MAD. And if we try to retract this, we are at high chances of creating new injuries. Everybody, even the experienced people, will try to do it very cautiously. And fusion is one of the best ways to avoid it by going more obliquely, avoiding the neural tissue. So what you want to do in these cases is avoiding all sorts of manipulation and retraction. And this is what you are able to achieve if you are going transforaminally. I've done 79 cases of this since 2013 to 2020, and the outcome had been good. And the failures were the two patients who the average duration had gone beyond the 2 hours of this. One of the patient had a root deficit after 10 days of surgery after he had improved. One patient with cauda equina syndrome took longer time to recover her other functions, and one of the patient failed and had to do an MLD. All other patients had given excellent results. Transdural approach, neurosurgical people, neurosurgeon friends, they are doing, especially for the upper lumbar. And this again is justifying that not to retract the neural tissue whenever there is calcified stenosis ventral, so that avoids that retraction and gives better outcome. This is practiced by many neurosurgical institutes. If you see the literature, there is hardly any literature for transforaminal calcified ventral stenosis decompression. These were an article in 2019 which had done interlaminar for the L5S1, but PTLD for all the other stenosis or disc calcified, which was above L5S1, and they had good outcome. But in their own cases also, they say that the residuals were more in the interlaminar because they had to retract the neural tissues. This is again the master himself, the Sebastian Rutan. They had reported 26 cases. This is for the thoracic disc. What they do is they do go extra foraminally and create a block osteotomy itself and create good amount of space. So this is a very limited indication and narrow zone. There is another case which is again for interlaminar discectomy, wherein they have done and the outcome had been good, but lower extremity dysesthesias do occur in interlaminar. So what we do is, for an osteophyte like this, you go inside there, you do the subannular decompression, then you use the burr to thin this part, then you use osteotome to cut it through, and that's how you retrieve that part which is actually creating the stenosis. Just for a video, which if it plays, so I'm just showing the focal part of it. So you just burr at the osteophyte. This is the dorsal part, this is the ventral part. You keep on thinning it. Once it is thinned out, the calcified part of the claw which has thinned out, you use an osteotome to break it off. And then it is a simple surgery as you do a transforaminal surgery. You pluck it, remove it, piecemeal, you keep on removing it, and finally you achieve a decompression. So this is what you usually achieve, seeing the nerve root there. So a case of double radicular case, wherein there was a calcified disc at L4-5 and L5S1, a doctor by profession had done a L4-5 as well as L5. You can see that decompression being achieved there. This is the decompression you had achieved. The patient went home. This is the patient which had a deficit after 10 days of his surgery. He came and said, sir, now I have a limp, and I observed that now he has got a L5 deficit. He was completely, he's a doctor by profession. He was completely okay. And then he developed it. And after 3 weeks, again, he recovered. So probably something went wrong in the form of a hematoma of something which I could not identify in an evaluation afterwards also, but he recovered finally. So this patient was a good outcome after a small hiccup. This is a case of L3-4 with complete stenosis, and I am a student, 23-year-old male. This is calcified there. He had developed the bladder ball symptoms also of chronic type, and wherein you had gone on the both sides transforaminally to remove it in entirety. And this is how you achieve the decompression with the myeloblock cleared. He was completely off his cauda equina syndromes itself. This is another patient of an D12L1, which is there. He is a boy of 16-year-old with paraparesis, both lower limbs. And that was again operated, and it was again on from both sides. And you can see the opposite side channel there. This is the free dura there. This is another case which shows the decompression. This is the case with the complete decompression there achieved. One of my senior friends and colleague, Dr. Kulkarni, has a paper on the posterior tubular decompression, wherein he has clearly said you do the posterior job, and by the posterior job you create a good amount of space, and there is a fallback of the neural tissue which achieves the decompression. This is very right. Today also I do many of the cases in the same way. This is just an extrapolation of what I do transforaminally. There was this case. This was again a calcified disc with an acute presentation of a disc which was there. So for the same thinking, I thought once that why not just remove the fragment and leave that calcified part there. So I went inside. You can see when I'm going in, the trocar is at that claw itself. I could reach there. I thought that I'll do the minimum there after reading his article. I removed that fragment completely. You can see it. The patient did not get relieved. I had to do an MLD in this patient. So I was just thinking if I can remove in a case of a chronic case with an acute disc, a massive disc, I removed a very good piece, but I could not get a result and I had to do a MLD. So message is it's an alternative procedure, can be done for consensus patients, but it does not lack that, it would lack that statistical robustness, definitely, and it cannot be gold standard because most of the people won't do it. Of course, we cannot compare the oranges and the apples. Thank you so much. Thank you.
Thank you, Dr. Ajay Krishnan, for a wonderful lecture and new procedure. Any questions? If there are no questions, okay, we move on to Dr. Sai Dilip. Dr. Sai Dilip, he will talk on PSLD, posterior stenotic lumbar decompression.
Good morning, my dear friends and esteemed people from all over the world. It's a proud moment for us to present about the stenosis and percutaneous stenosis decompression. So after the start of the interlaminar endoscopy, the things have started growing up. The paradigm shift of the technology has shifted to such a good level so that the things, the instruments and the burrs have changed the scope of the surgery. So since when the initial endoscope surgery was transforaminal surgery, so the people are doing good work. When high iliac crest was the issue, they started with transiliac approach, and slowly interlaminar approach was comparatively less minimally invasive than doing transiliac or something. So then they started doing the interlaminar approach. So when you were able to go to the posterior decompression was possible with interlaminar approach, then the things, the scopes, the angulation, the vision has changed, and instrumentation by the great legends has started. So the things have improved to quite a new level now. So it's one of the monoportal surgery called as percutaneous stenoscopic lumbar decompression, and now it has shifted, the paradigm is shifted to thoracic decompression and even cervical decompression. And there are great legends who started doing even anterior cervical surgeries with stenoscopy. So stenoscopy is just a surgical intervention where you use a monoportal scope through which the instrument passes down. So where you're going to do everything through the same port and the same thing, including the ipsilateral, contralateral, and infusion surgeries too. So as my topic is more of for lumbar decompression, yes, so the indications are any kind of subarticular herniations, normal lateral recess syndromes, or central canal stenosis. Yes, some amount of foraminal and extraforaminal stenosis, which I'm going to discuss in the future. So contraindications, the things are coming down seriously before there the instability where the visualization for the entering of the laminar window was a tough thing. So it is definitely a contraindication still for the endospine surgeries. Previous posterior surgery, it was definitely an indication, contraindication for not doing the surgery because of the adhesions. But since the endoscope has a good visualization, as my friends before told, if we are very careful, electrophysiological monitoring, if possible, yeah, we can try to do that. So technique, it's just like the normal endospine technique. It can be done. It can be done under sedation. It can be done under IV sedation and local anesthesia. But my preferred choice is epidural, single shot epidural, and general anesthesia if the patient is not compatible. Prone, the position is prone position, Wilson frame. We want the laminar window be open. So, as previously discussed by previous lecturers, so it is like we are doing endospine surgery. We try to visualize too magnified. So the amount of bony work should not mitigate our concept of surgery because the target point is very important. So according to me, a good laminar window creation prevents us less bony work, less time, surgical time, and definitely we can take care of the main thing which our target is. So obtaining these procedures is important because creating a laminar window, these kind of radiological advantage can be taken. So the end plates can be parallelized, and the laminar window can be very much clear, so that the scope angulation doesn't go too dorsally or too ventrally, or the scope doesn't go too cranially or too caudally. The surgical technique is, again, the surgical technique do vary according to me in stenoscopy. So it is your obviously your pathology which you are treating. So if your pathology is more towards of a disc herniation, my entry point is towards always a bony landmark. So the entry is always towards the medial facet. But if my concept of surgery is more for stenosis, I end up with the spinal laminar junction, just like the UBE. So after preparing of the soft structures, after we take care of all the soft structures and also the bony overgrowth, if you want to dissect it, so you can start with the spinal laminar junction, you can do the cranial laminectomy, and you can do the medial facetectomy, and next comes the yellow ligament. So since the sublaminar yellow ligament is thick in the cranial side, so it has two layers, it always better to start from the cranial side. So then comes the medial facetectomy. So it can be done alpha S1, the requirement is quite less. The requirement comes up with the higher levels because the facetal orientation and facetal growth is different. So high speed drill has changed the story of the surgery. So next, after doing the dissection of the facetectomy and of the ligament dissection, then we enter into the space with the golden window where you see the epidural vessels. So epidural vessels and epidural fat is the initial sign of that we enter into the neural structures. So if we are planning only for a discectomy, it is just plain, just do the discectomy, retract the neural structures like the interlaminar structure, interlaminar technique, you just retract and you can use a sleeve and you can use the normal working sleeve. So medialization of the neural elements with a blunt dissector, or you can use the working channel itself as a dissector separator for your disc, and you can start do the discectomy if required. So complications is the same like UB or same like the open surgery. We do face intraoperative dural tears. Intraoperative bleeding is quite a troublesome because it's too magnified and visualization is a little tough. So the meticulously and postoperative hematoma is quite evident. So my preferred choice is putting a drain. So postoperative hematoma is quite commonly seen, and also some neurological symptoms if the irrigation volume is too high. But I have not seen much of those things. So until now, this was kind of the main topic for me. So after knowing the basic approach of stenoscopy, so there was this ideology, the paradigm shift from the transforaminal to foraminal surgery. So interlaminar surgeries, the things have changed because the interlaminar axis was tough to take care of the foraminal and extraforaminal herniation, or because of the scope is fixed, so you can't go down. So though it's a joystick in your spine, it's like a joystick in the spine, so you don't end up going to the foraminal extraforaminal herniations. So there was a new technique. It's not a new technique, it's an old technique of the open surgery. It's called a paraspinal surgery. So it has been advocated. So paraspinal surgery is just a technique where you go into address extraforaminal and foraminal herniation. So as I told, I use a 8.5 mm outer diameter scope with 5.7 mm inner diameter, which has a 12 to 15 degree scope. Everything is okay. So radio frequency probe is required because foraminal structures do have epidural vessels, quite amount of epidural vessels. So the other instruments is the root retractors, and you have your Carricin rongers. We have a curate dissectors and the high speed drill definitely. So usually the skin incision for paraspinal surgeries is just like the normal routine. You can take it up with 4 to 6 centimeters parallel to the midline, or you can end up with the lateral line of the facetal line, or you can just end point to the transverse in the facet line also can be a good entry point. So maybe this it's maybe integrating point, or it may be helpful point. Transformal approach to transcambrian approach, you are directly facing towards the root. So the injury of the root is quite common in transforaminal injury. But since we do the transforaminal surgeries under local anesthesia, so the patient do complain about the root pain. So we try to be more careful. So probably the amount of injuries we see is less. But in para-PSLD, we are quite parallel to the root. So obviously the chance of injury is quite less compared to the transforaminal approach. So, but the technical expertise is little tough. The anatomical orientation may be little tough. The amount of bleeding may be tough. But if really the patient requires extra foraminal surgery, para PSLD can be a good option for us. So it's just an option for us. But the surgery can be easy if it's a disc herniation. Definitely, still I prefer transforaminal approach. But if I feel it's a foraminal stenosis or extra foraminal stenosis, then this para PSLD can be tried. So after opening the we see the final position of the things. We directly visualize the scope and we see all the anatomical structures. This is a case of L3 L4 stenosis. I'll be showing it. So where we have done it, we have done stenoscopy and decompression for foraminal. You can see extra. I think you can see a far lateral extra foraminal disc herniation. So this is how you can see the post-operative imaging. So this is how we put a drain in the foraminal line. So it's better because epidural hematoma is the most common complication we see around with para PSLD. But it's any kind of endoscopic surgeries. I prefer to put a drain in interlaminar access. So these are the foraminal structures. Higher levels you may encounter sometimes a foraminal arteries and foraminal branches of dorsal venal arteries and all, but usually you don't end up with those kind of stuff. So in the lower levels, even for L5S1, L4, L5 extra foraminal approach. So these are the images of what we see in the medial and the cranial and the caudal aspect. So intraoperative changes, these are the changes, these are the drain is kept. So this is just an image how we do. So these are since the instrumentation is quite less for the stenoscopy, you need two kind of ronges and two dissectors and a kind of disc punch. Most of the surgery can be taken care of. So these are the instrumentation which you use for the PSLD. This is the approach, the ipsilateral approach, how we do the medial fasciectomy, how you do the laminotomy, and if you want to do the contralateral decompression, this is the approach. So I just put on all the slides because my topic was quite different. So the steps of PSLD is my tomorrow topic, and now extra foraminal topic is today's topic. So it's just like the reverse it should be. So these are the steps of PSLD where you start with. It's a Jenny Ito has given this presentation. So this is actually, it was missed. So this is the post para PSLD approach. You see, this is the structures. What you see? You see the transpositors here, and you can see the root. You can see the SAP. You can drill the SAP from the outside, and you can just search the neural structures and take out the disc. So these few of my patients which I have done, this is a case of cervical, these are few of transverse para PSLD, these are the incision for normal, this is again para PSLD. So these are the procedures what we do regularly in our hometown. These are the few videos after the post procedure, post paraplegia with extra foraminal herniation, patient complains of severe root pain. So immediately post operative, the patient starts walking. And these are the few videos how we do the endo drilling. This is a case of a failed back surgery, open surgery where there's adhesions were there, which we taken care of with the PSLD scope. This you can see more of how the root dissection can be done. It's a post of a cervical foraminotomy. Thank you. Any questions?
Sai Dilip, did you face any particular difficulties when you started a para PSLD approach?
Yes, definitely para PSLD approach is a technically tough situation because the anatomical landmarks do differ when we started. But since monoportal surgeries, the docking point and endpoint surgery is always a landmark. So you feel comfortable whenever you miss the landmarks. So my gut feeling is initially, yes, to finding out the landmarks was a tough thing. The bleeding was a tough thing. So the flaval resection ended up with initial cases. I was having a tough situation with the epidural ooze and all. But now after you know the orientation, after you can find out what is the SAP, what bone you are on, which lateral part of the bone you are on, you can feel the transverse process with the hook and all. Now how to separate the foraminal ligaments. So it is better, but I don't say it is it's kind of a technically easy procedure, but it is definitely tough. But it works out for few patients.
All right. All right. Okay. Thank you. Thank you very much.
Thank you, sir. Thank you very much.
Let me call upon Dr. Madhuchit Gupta for his talk on transphenomenal endoscopy for caudal equina syndrome, a case presentation.
Everyone. I'm really thankful to Dr. Malcolm for this kind invitation, and especially in this particular case for his constant guidance. In fact, my previous speaker, Dr. Krishnan, also has published a case series on cauda equina. Is that right, Dr. Krishnan? Yeah. So, acute cauda equina syndrome, it's indeed a devastating situation for a young patient. So I'm presenting a case of a 28-year-old health freak IT professional who had a history of low back pain with left-sided radicular symptoms for quite some time, and he was managed conservatively and he was doing fine until one evening the patient's gym instructor called me that he was exercising in the gym, and suddenly he developed severe back pain, and he's unable to stand or even bear weight on the left leg. And on top of that, he actually wet his pants without even realization. So he was in immense pain and unable to control urine. The erectile dysfunction, this was discovered once everything was over. After the treatment, he discovered that he was facing this issue as well. So he was brought to the hospital. On clinical examination, the SLR was 20 degrees. The muscle power was weak on L5 and S1 root zones. Ankle jerk was absent. Sensations were reduced in the left leg and foot. Anal wink was absent. Bladder sensations were gone. So we had rushed, given some IV steroids and did the necessary medications which were to be given, and rushed him for a MRI. It showed a huge extruded fragment at L4-5 and almost completely encroaching the spinal canal. So we just planned a transforaminal endoscopy for this patient under local anesthesia within 24 hours of the onset of the symptoms. As with transforaminal, we emphasize a lot on the correct needle placement, where the target zone. So just to give an analogy to the importance of that, I'm just showing you a little. So you need to reach to the tail of the fragment, target your needle, because everything follows that correct needle placement, and you take out the fragment out. But the thing is, you don't have to break the wall of the foramen. You can always carve the foramen with your burr, and if necessary, and take out the fragment. So here we place the needle exactly in the posterior 1/3, and in the midline, you can see the free dye leak in the epidural space. So we landed right on the fragment, extracted the first fragment to make some room. We teased out the larger fragment using the hook and took out the large fragment. So this is where we landed, exactly on the fragment. We debugged the fragment. And many a times, if a fragment is too big, it just gets stuck there within the cannula, within the working sleeve. So the first fragment was out. Still a lot was there. So we use this wonderful bendable hook to tease out the fragment in the working sleeve. So we brought in within the working sleeve. Just took out the fragments out bit by bit. It got stuck, in fact, in the working sleeve. The fragment is so big. Finally, we managed to get hold on it and took out the fragment. So there we just could see the big rent, and at 12 o'clock, the free nerve root there. Some remnant of annular tissues. So this is what we got. Post-operatively, the back pain reduced immediately in the post-op. Third, fourth post-operative day, there was some bizarre shooting pain in the left leg due to dysphagia, which was managed by high doses of gabapentin. After 4 weeks, bladder sensation started coming back, but still the patient had to be in adult diapers. After 6 months, motor power regained up to 80%. And finally, the patient was a thankful patient, having regained control over bladder and muscle power in the affected limb. It's been almost 2 years now. In fact, more than that. The patient is doing fine, perfectly well. And most importantly, his sexual dysfunction was cured completely, which was of his major concern when he discovered it was there. Thank you.
Thank you, Dr. Gupta, for this nice talk. Any question from the audience?
It does take a long time, sir, because once he discovered that it was there, because when he was in pain, he hardly bothered about that thing. But after 1 month, he, started complaining that this is the issue, and he was so anxious and disturbed with that. Almost 1 year, I think, would have lapsed that he was bothering us for this thing. But afterwards, it recovered, and since he's not bothering me for the last 2 years now, so I believe it has recovered.
I in fact sent him for counseling for some time.
Okay.
Do you think which way is safe, like this case? Posterior or interlaminar or foraminal?
Yeah, I had first, suggested him to go for, and when I did this case at that point in time, I was not doing interlamina, not PSLD. I was just doing transforaminal endoscopies. So I had sent him initially because he came from quite a distance. I had advised him to rush to the nearest hospital and get a surgery done, even if it's an open surgery or whatever, microdiscectomy, get it done immediately. It is urgent. But that night, only in the middle of the night, he landed up to my hospital saying that I just don't want to. Coincidentally, he got one of his aunts operated for spine, with which he didn't have a good experience because she was still bedridden. So he was adamant on that I am not going any kind of interlamina kind of a thing. I'm not going to get an open surgery done. But still, I believe had I been doing PSLD at that point in time, I would have gone for that.
No, actually, like these cases, sometimes transforaminal is safe than posterior, because if you go the interlaminar, you need some retraction,
Root retraction.
roots, or you otherwise you have to do some facet joint resection.
Exactly.
Otherwise, this transient injury, nerve injury, can be constant because of the posterior surgery. So the transforaminal may be safer than posterior for this
But
like cases.
my concern was, sir, that in case I miss out on any fragment which is remaining, so that way interlaminar gives me that leverage of seeing the entire thing has come out or not. In transforaminal, yes, many a times we miss out on a fragment.
I have about 5 cases of that. Because they're all L5S1 for my cases, so I did the posterior. But I do a stenosis scope first. I find that a lot of the cauda equina disc, actually, the moment you take out the flavum, the disc is right there.
Exactly.
You don't even, a lot of time I don't even need to switch scope or use a smaller scope, the stenosis scope. Just use just use the freer, the Penfield, and then the big whole piece of big disc came out. So might be easier in especially in L5S1, but I would advise to do a stenosis scope, take out the flavum, don't do those flavum splitting or use a punch, ligamentum punch type of thing and squeeze your scope in. They can't take more space. So second thing, I usually do a MRI post-op. I think these patients need to know that they take time to recover.
Exactly.
So personally, I would to treat me more as well as the patient, I would do an MRI to show that, oh, we did a nice job, so that they take time to recover. They won't ask me, how come, is your scope okay? Did I have another fragment that you left behind? Things like that. I mean, just
I understand your concerns, sir, but many a times, there are some financial concerns with the patient. We had almost done this patient for free. We had operated because he had just managed to, pay the hospital bills for the OT charges and all. And we kept him just for a day, and next day he was freed on catheter, which was removed later on. And yes.
Yes. I also want to share my experience. The thing that you have to concern is the adequate of this removal. The first thing, and the second thing is the stenosis combined with this herniation or not. And the third thing is how the last fragment of the disc, some cases penetrate into the dura. You see the interdural herniation also make the cauda equina suddenly. So you have to consider, and then you see in your hand, you have a weapon or not. If you're familiar with the transforaminals, that's okay, because if you do the procedure the best way, but you're not familiar with, maybe more dangerous, right? So, but for my experience, I found that transforaminal sometimes, even I try to do my best. And some cases have the lesser this inside the epidural space. And we very hard for me to say, oh, I want to perform second operation for you, right? So nowadays, my practice, I start with the decompression first, but not small, not try to make the small hole. I make the large hole. I want to see from the upper root until the lower root. And then I identify the disc fragment and not attempt to tag the nerve roots, just pull the disc to the laterals and then remove from this space for the epidural space. And then you can see how adequate you remove the fragment. Normally they have 2 or 3 large fragments, not only one. Okay, thank you.
I would just agree and disagree. What Hayati was telling exactly, you are not creating any retraction of the roots when you are doing transforaminal. But at the same time, the concern that you are completely decompressed, that is the biggest concern with transforaminal. But whatever has been taught, and if you go through the Bensel, that is our own big book which we have read long back, the Cauda equina syndrome, the technique of decompressing itself is, like sir said, you put a lateral annulotomy first, but you're not supposed to pull it laterally out. Rather than you are supposed to push the fragment back into the disc space which is created. You are not supposed to retract or manipulate the neural tissue which is already in a jeopardy and probably half dead or maybe fully dead. A manipulated root may not manifest immediately because you're already handling a dead root. So that may not manifest there and then. So that's the reason why these patients are not having that much adequate outcome in the long run. One of the articles in the European Spine Journal, it said it is 20% of the iatrogenically induced Cauda equina syndrome out of 100. That's a big percentage. For a master like you, everybody can get around. But beginners who do Cauda equina, it has to be a hell lot of a thing which has to be considered to be out of it. One more thing to add, the general anesthesia itself is associated with post-operative urinary retention, that is POUR. That's a very mentioned thing. So when you're doing a surgery under local anesthesia, you're completely avoiding the manipulation part, the general anesthesia related, the stasis of the urine, the balls. So that all adds to the faster recovery when you're doing a surgery of transforaminal for a Cauda equina. But to be doing it as a gold standard, it is not possible because anything left on MRI, the patient can sue you. So it cannot be the gold standard as of now, and you have to achieve an MRI based decompression completely. Then only you can attempt it.
Thanks all. Can we move?
A small add-on, very well said. When the disc is finally covered, tented by the neural tissue, is good to go from the side, perfect. And when you have a dorsal disc, you can go from the posterior. Another thing is when you see all this removal of the fragments and you're worried about the fragment left over, sometime I add on epidurogram on the table and see if it's nicely cleared out. So I'm more comfortable. So a neural structure is now cleared.
Okay, thank you.
Sir.
But what is the jury saying? You have to have an adequate decompression or just pull out the fragment and cause more damage? Because the cartoon showed something else.
Just to maybe have a different way of thinking is if you decompress transforaminally, to combine the surgery with a UBE afterwards, and that way you have direct visualization for any remnant fragments, and make sure that you're getting your laminotomy with that. I don't know. It's just a thought.
Okay, no more question, please. We can invite Dr. Ketan from India to give his talk about UBE cervical laminopharamatomy.
Dr. Ketan Deshpande.
Yeah.
Yeah. Dr. Ketan is from Pune. He is a very passionate UB surgeon. He's also teaching UBE to the beginners also now, and he'll be presenting his talk on UBE cervical laminoforaminectomy.
Thank you for that introduction. I'm very thankful for the organizers for giving me this opportunity to present my work here. And I'm also very glad to have Dr. Omjinwa here. He's my UB teacher, my mentor, and to present something like this in front of him is a really proud moment for me. So thank you for that. My topic for presentation is UB posterior cervical foraminectomy. So it is basically endoscopic assisted laminoforaminectomy. The indications are a paracentral disc or a foraminal disc or a foraminal stenosis that is causing typically unilateral radicular pain. As we know, unilateral biportal, the name itself tells you that there are two ports and they are on the same side of the midline. So the name UBE. When we ask ourselves when we think about any new technique, we should ask ourselves these three questions: that what is this technique, why is this technique, and how do I do this technique? So why do we need to have an additional technique when we have so many techniques here? So the major advantage, in addition to being very close to the tissue, your eye being inside the body of the patient, is the medium of the surgery. When you introduce the water medium and change the air medium of the surgery, that is, I think, a major key factor. In addition to uniportal endoscopy, biportal endoscopy is giving you a freedom of the size of the instruments, because unlike uniportal endoscopy, where your instruments are going through the working channel, here your instruments are moving independent of the scope. So you can introduce as large as instruments, you can move them as freely as you want. So that's a major advantage. That's why we're learning this particular technique. This is one of the videos that I show in all of my presentation, that unless you have these kinds of good outflow of fluid, which is coming out without any pressurized pump or anything, just gravity aided, you should not begin your procedure. So that's a major thing that you need to learn first, how to get this fluid out, and then only you should start working your way inside. Sorry. So the operative preparation is, we do it under general anesthesia in prone position with the neck as flexed as possible. We use a specialized drape that has got a fluid collection bag, so that your operative field, your OT remains clean, and we should position the patient in such a way that the C-arm is freely mobile across in the AP as well as in the lateral direction. So this is just a rough representation of how we position the patient, making sure that the neck is adequately flexed. Then we drape the patient like this. So you have an IO-band or a centralized IO-band that is connected laterally with a plastic bag, so that whenever you're operating, all the fluid that is getting collected across can be drained out very easily and doesn't make the OT messy. We start with the skin marking, then we develop the working and the scoping ports, followed by triangulation and decompression. So this is how we mark. So the left side, you have the cranial side, the right side is caudal. We here, irrespective to in reference to the pathology, we stand on the symptomatic side of the patient. So if it is a right sided, we'll be standing on the right side. If it is left sided, we'll be standing on the left side. The red line is indicating the midline. Then you have a scopic portal that is coming in from for a right-handed surgeon, the scope will be held in the left hand. So it is coming in from the cranial side, the working portal that is coming in from below. And we do this marking by taking C-arm shots. So the first point that we do is mark the midline. Secondly, we roughly mark the disc space, that is going to be our scopic portal. We place two in the lateral view. We place two metallic dilators. The top one is the one which is through which the scope is going to come. So scopic portal directly on top of the disc, working portal roughly 2.5 to 3 centimeters below it, coming in at an angulation. And then we go inside and then we start the procedure. So in this video, you can see that we are already on the interlaminar space. The left side of your screen is the cranial side, right side is the caudal one. And you have the cranial lamina on the left side and the caudal lamina on the right side. Initially, we have to do some soft tissue clearance so that to expose the cranial, caudal lamina, the interlaminar space, that's the orientation for you. So after doing this, even though the docking point is at the medial most part of the lamina, our working part is on the lateral aspect of it. So we start by drilling the cranial lamina on the lateral 1/3 part of it. As we all know, in cervical spine, the lamina are overlapping. They are significantly overlapping, especially towards the lateral part. So this overlap, we need to do the foraminotomy or the laminotomy and expose the ligamentum flavum. Unlike in lumbar spine, where the ligamentum flavum is deficit in the middle part, in the central part, here the ligamentum flavum is deficit in the lateral part. So you actually have to go to that point. So that is your end point of doing bony decompression. So you have to find that paper thin cortex wherein you can put a probe or you can put a 1 number Kerrison underneath it and open the epidural space. So like in lumbar spine, we start from the cranial part, then come medial to lateral, we can remove the ligamentum flavum. Here, you have to make sure that the cortex is paper thin. You can actually see that instrument through the bone. So it is that thin. And then you start using your Kerrison rongers there. So 1 mm Kerrison ronger can remove that overhanging part of the lamina. And soon you will come to the point where you'll be able to see the ligamentum flavum is almost deficit and you can puncture the flava there and actually enter the epidural space. So this is just a 1 mm Kerrison and you need not worry about the cord because we are far lateral in this case. So 1 mm Kerrison being introduced under the lamina is not a problem here. Now you can see at almost 7 o'clock position, that is the flava deficit. So you introduce at exactly that point, that is the flava deficit. So you introduce a curate and you start making your cuts into the flava. Now we have exposed the epidural space. So you'll see a lot of fat. And unlike in lumbar spine here, the root is coming directly towards you. So even though it is a traversing nerve root, it comes directly towards you. It is not going parallelly like this. So you will have the thecal sac in the central part with the cord and the root coming directly towards you. Now it depends on where what your target. If you're just doing this for a lateral recess stenosis or a foraminal stenosis, removing this part of the ligamentum flavum and some amount of lamina, you are good to go. But if you're doing this for a disc herniation, then definitely based on the preoperative MRI readings, you are aware that whether the disc fragment is in the axilla or the shoulder. And depending on, you have to expose that particular area. Here, the disc fragment was located at the axilla. You can see that there now, that white tiny portion which I'm about to poke, that is the disc herniation, which has pushed the root posteriorly and cranially. So you just nibble out, you just tease out the disc fragment and you bring it into the center of the field. And with the help of a disc forceps, you can easily lift that disc fragment out without any central neural tissue retraction. So such large fragments can be very easily nibbled out. Always there are multiple fragments, so don't be very happy after you remove a large fragment like this. Always check for the residual disc and you will find that there are more fragments that are ready and waiting to come out. And that's the end point. So midline flava we haven't removed. That's the lateral edge of the cord with the axilla clearly decompressed in front of you. That's not a twin nerve root, but the ventral and the dorsal nerve roots conjoining. So it's a very common finding for endoscopic spine surgeons to see two roots like this later on combining to form the nerve root. These are the skin incisions. The major difference when you're doing a lumbar and cervical UB is in lumbar, you have a good perception of depth and you have a good tissue differentiation. So where you go from skin, subcutaneous tissue, facial, and onto the bone, you have a good tactile feedback that you get. Unlike in cervical, it is very difficult, very small space, very much crowding of muscles. Secondly, in lumbar spine, when you try to do and create some working space, laterally, you have the facets who restrict your lateral movement. So in cervical spine, the laminar flat and the facets are anteriorly. So if you keep on doing that, you might slip anterior to that. So there are some key points that you should keep on checking your CM regularly, at least in the initial part of your surgery. So what we are trying to do here is combine the versatility of tubular decompression and adding the advantages of uniportal endoscopy in the form of minimally invasive and water medium to in the form of unilateral biportal endoscopy. We all know the advantages: fluid medium surgery, the anatomy is familiar, better visualization, direct access to the pathology. So they are the main advantages. I would like to take just one more minute and invite you all for this mega event that is coming up in November. In Pune, we are doing the 7th annual gathering of minimal invasive spine surgeons of Bharat. It is going to be a big conference from 18th to 20th of November with a pre-conference human hands-on cadaveric workshop conducted on 17th of November at Kashi Ben Ole Medical College, Pune. We have a plethora of international faculties who are expected to join us. So please do join. And the regular team from ESFI will be there for UB. Thank you so much.
Thank you, Dr. Ketan. Any comments or questions from the delegates or the audience?
Okay.
What is
the nice presentation?
Thank you.
What is the recurrence rate of cervical disc?
Sir, I think the recurrence rate is irrespective to the procedure that you're doing. I think it will be same with that. I don't have that much of experience. I might have done around 15 to 16 cases. I don't have a single recurrent in cervical disc. Even when I was not doing biportal or uniportal endoscopy, this is the way that I was trained. I was doing posterior approach, try and avoid anterior approach, try and avoid fusion and preserve the motion segment. So I don't think the rate would vary from just because we are doing it endoscopically.
What I'm saying is we keep moving the neck all the time.
Yeah.
You know, the movements of the neck are so much.
Yeah. Roughly speaking, we tell the patient it is going to be the same thing, around 5 to 7%. There are chances that you do that. And protocol wise also, I put them in a cervical collar for 2 to 3 weeks following. Otherwise, mobilization will start as soon as the patient is out of general anesthesia.
Okay, great.
Okay. Nice presentation.
Thank you.
UB surgery is totally based on the open surgery. The result and every procedure is the same as open surgery. Also, you talk about recurrence rate. I think it's the same as microsurgery and open surgery. UB surgery is not different, I think. So one more important thing is if you're doing a cervical discectomy, we have to remove foraminal area. So we have to preserve a foraminal area very safely because worry about postoperative instability. And before posterior approach, the open surgery is also the same. If we have a cervical kyphotic change there happens, I don't recommend the posterior approach. Okay, you have to preoperatively, you have to check the curvature of a cervical spine, and you have to think about plan for how much you have to decompress the foraminal area. So that's the key point. Yes. Very good job.
Thank you.
Congratulations.
Thank you.
Yeah. I would like to ask you two questions. One is the water pressure, because I'm very worried about the pressure, right? How much for the water pressure that you use? And the second question is, how can you consider about the location of the disc? This is far from the medial, how much? Because in some cases, you cannot remove the disc because it's too medially, right? So how can you determine this case should be possibly a foraminotomy, something like that?
Yeah. About water pressure, I am not using any pressure pump or anything. I just use gravity aided. Just approximately my height, the saline irrigation stand is there, so around 6.5 to 7 feet. I put this thing. Initially, only I make sure that if I don't have good outflow of water from the working channel, I do not proceed with the surgery. Initially, in few cases, I had that similar problem. I think the major problem was creating too many puncture holes in the fascia and allowing the fluid to extravasate between the fascia and the subcutaneous tissue. The skin swells up. You have a good field, the skin swells up, but the water is not actually coming out of it. So that is a major problem. So I realized that the amount of working space creation and the tissue dilatation that you do in the initial part of the procedure, that plays a key role. So as long as it is gravity aided, not a pressure pump, and there is free flow of fluid. Secondly, in some cases in lumbar spine where there was very hefty patient, I had to use a pressurized pump. The first indication that you get is the patient's blood pressure rises. So irrespective to the rest of the parameters, an unexplained rise in the blood pressure on table that will tell you that there is a lot of irrigation pressure that is being created. There is a lot of epidural pressure that is being created. In those cases, we wait for some amount, we put a dilator, you let the fluid flow out, and once the pressure settles down, you can again continue the same thing. Or instead of directly going percutaneously, you have an assistant who's retracting the fascia with an and keeping the working channel open, so that it helps. About the location of the disc herniation, my way of thinking is, if I can do it via a microtubular approach, then I can do it via endoscopy, via UBE approach. So a centrally located disc herniation which is slightly calcified with a long history, I will never attempt it like that. But a paracentral disc herniation, if I'm able to just poke it and remove it, so something which is located lateral to, in the lateralmost part, causing a unilateral radicular pain, I'll definitely give it an attempt. Although we do conceal some of the patients which have that kind of, or even if the disc is migrated downward, because there is a pedicle downwards which is going to restrict your, unlike in lumbar surgery, in cervical, you can't just go on, keep on going downwards. So migrated disc herniation would again be a relative contraindication in that case.
Okay, so
Yeah.
the cervical area, the water pressure is very important. So we measured already water pressure, and there is some data. And 30 millimeter mercury is will be fine, but sometimes cervical muscle is too deep. So that's the reason we have to use the working portal and endoscopic portal. You have to use working portal in the cervical area. You must use. In lumbar area, you don't have to use the working portal. But good normal saline passage, you have to use the working portal in the cervical UV laminotomy, foraminotomy. And the maximum pressure will be maybe, we think, 70 to 90 millimeter mercury. Already we measured the study about that.
But
Thank you. We now thank you, Dr. Deshpande. We now go back to the operation theater. We are just running 40 minutes behind schedule. Yes, Dr. Malcolm, tell us how far you have come.
So we are in end plate preparation mode.
Okay. Can you orient us again?
We're finished with the curating. You all must have seen the rotary curettes working their way inside. A lot of adherent tissue. So it's what I'm going to tell you, that many times we feel that by using the rotary curette and pulling out a few fragments, you remove everything. But that is far from the reality. The reality is there's so much of tissue that is still on the end plate. And now we are physically removing all this tissue from the end plate.
What instrument are you using to remove the tissue
I'm
from?
using a Bonds company 90-degree probe.
Do you use a curette also?
I'm using it at a low power, so temperature is barely 50-60 degrees of plasma there.
Do you use curette also or no?
I can't hear you, sir.
Do you use curette also?
Yes, I will be shortly. Give me 5 minutes, I'll show you the use of the curette also. I'm trying to make my paths use it so badly collapsed that you can barely see a 3 millimeter instrument going in. Stop, please.
Which instruments you
Inside is
prefer?
nice. So now we will be using the curette. Can I have a curette, please? Yeah. And can I have a arthroscopic hook? The reason for the hook is to map the level of my progression inside the disc.
When do you have to use a motorized instrument to clean?
I don't really use a motorized instrument inside. Some people do prefer to use a shaver. I prefer not to use a shaver. I prefer to do it manually. It takes 5 minutes more, but I feel more comfortable.
Is there any reason for that?
So you can't use suction with a shaver. So basically the concept of shaver really doesn't work over there. And shaving by manual method, by using our shavers that we've already done. So there is no great advantage of using a mechanized shaver there. You can't use suction in, so what is the point? Your shaver is going to shave nothing literally. It's just going to rotate inside and come out. I have a mental satisfaction that I use the shaver, but beyond that, really nothing much. But you can see how the end plates are shaping up now. I'm putting the scope into the disc and out. It's a little fast. 2 hours is roughly.
Ever use a burr?
No, sir, I don't use the burr. I don't want to use the bus. No, sir. I prefer to do it manually. Be safe than to be sorry. Curate, please. Yeah. Can I have a hook? Now this hook will tell me where I am as far as the end plate is concerned, and am I at the other end? There's a piece of tissue coming between. Sorry, guys, 1 minute. Let me just give me a kerosene to attend to that, so I can show you a little better.
Since you are looking from posterior side, how do you know you have curated or the end plate far anterior? Is there?
Scope will be going in, and I'll be showing you.
And tell us the
It towards the roof, and I'm going to bite away into the roof. There's a lot of space restriction here because of the collapse. But one has to deal with it. This allows me to go and see the roof better. Now I'll use a curate to remove material from the roof. So what I do is, and what you're supposed to do is, you're supposed to come out, see your instrument go in, and then chase the instrument into the disk space. Never blindly put anything in, even if you are guard, because you can damage the neural edge. Last thing that I would want to do. And you can see how I'm using the curate to strip the inlet. Nicely, chunk by chunk, all comes out. Just a little patience. You have a disk punch, please keep two things ready here. Yeah. Unfortunately, it's very tight, so now I'm putting in my disk punch and I'm getting that piece of cartilage out. The angle of the disc is not allowing me to grab something from that side, so the curate only to mobilize it out into the front. Yes. I should be able to grab it. You can see the end plate being prepared quite nicely. Very accurate. The advantage of using the curate is that you can literally target every millimeter that you wish to. Now I want to target this zone, so I can target this zone. I want to target this fragment now that is contralaterally there. So we'll pull all this in. Empty out all this. And most of it just floats away with the fluid. This little edge of tissue is also going to go later on.
Should we start the lectures for some time?
Yeah, sure.
Come back?
What you can see is that I'm working on the opposite side.
Yeah,
The
yeah.
opposite side.
That's what
I'll
I'm.
show you this young shoot later.
Yeah.
So please continue your lectures.
Okay, thank
When we
you.
prepare the entry.
Thank you.
Demo grafting will cut back in.
All right. Dr. Jang, can you
Yes, sir.
be the moderator for the
What's your
next?
excuse me, sir?
Dr. Jang,
What your name?
you are the moderator for the next session. Dr. Nantawab Utamo. Yeah, all right, please.
Okay. Next section. The presenter is Dr. Bang Hung U from Singapore. He will talk about the uniportal lumbar endoscopic unilateral laminotomy with bilateral decompression. 12 steps of efficacy. Please.
Yeah, greetings everyone. Thank you for your invite again for the organizers. It has been a wonderful time that I have in Mumbai. Yesterday I talked about UBE in the adjacent segment. Today I would like to share about uniportal lumbar endoscopic unilateral laminotomy bilateral decompression. I mean, there's another talk that's on PSLD. There's another version of the same name. And I've published a paper on 12 steps of efficacy. I would like to share that at this moment of time. So as I mentioned yesterday, I practice in Singapore. I take care of the western part of Singapore in the government academic practice, about 12% of our population. I do half my surgery, uniportal, the other half biportal. That consists of 80% of my cases. I do some open surgery for trauma, infection, tumor. So I think the indication has been covered by my earlier speaker. So just would like to highlight the main difference between uniportal and that of the tubular. As you can see on this left-hand side, there's a tubular schematic diagram decompression. We do a ipsilateral decompression after we place the tube at the correct position. And then we do a contralateral over the top decompression. While that on the endoscope, the scope is placed more deeper, and then the lens is directly on the front of the scope, and we can do over the top decompression similarly. However, there's more mobility, and then the visualization is the anterior aspect of the scope. So there are main two types of decompression in uniportal surgery. One is an inside-out technique and outside-in technique. For the inside-out technique, basically we do an ipsilateral laminotomy and then take out the flavum, and then we will go underneath the flavum of the contralateral side between the epidural fat layer and that of the flavum, and then we do a decompression of the contralateral side till there is epidural space, till the dura is decompressed. While outside-in technique, we do bony work first, preserve the flavum, the deep layer of flavum, and then complete the decompression before we remove the contralateral flavum first and then the ipsilateral flavum. So my practice is mainly outside-in technique, although in some cases, if there is some, for example, if the endoscopic drill is not working very well that day, then I will do an inside-out technique. So I recommend that you know both techniques well. In the setup, this is the main setup that I have. It's very similar to others. I use a pro-axis table. You can use Wilson frame. There's no much difference on that. And this is the paper that we published in Neurospine about a couple of years ago. As you can see from the right-hand pictures, we dock on a little bit lower. We do a sublaminar approach. So we dock on the pedicle of the more the caudal vertebra. And as a result, just on the medial pedicle line. So when we decompress, we're actually looking up and do a sublaminar decompression. Rather than if you dock on the spinal laminar junction, which I do in my UBE practice, as well as in some of the inside-out technique that I do, then we will dock on the spinal
I think we have to understand our scope well. So in a typical, for example, big scope where 13 mm outer diameter, then you have to create enough space for you to be able to go contralaterally. If you have a smaller scope, then you do not need to create dissect so much of the spinal laminar junction. That aside, as you can see here, we have complete ipsilateral laminotomy till the cephalic paper thin till the dura is free. Then we go caudally, and then we resect till the dura again paper thin. I have proper video to show. And then we remove the contralateral side first. Reason being, I find that then you can control the bleeding on the contralateral side first, easier. Then I do the ipsilateral flavectomy. That's just my personal practice. You can do the other way. So this the actual video showing that what we do. So as we mentioned, we do a cephalic laminotomy, then we free up the flavum. We now go on to a contralateral side. We tend to need to remove a bit of superficial flavum to assess that. So now we can see we remove the contralateral flavum now over the top. Just sufficient enough, and then we remove the ipsilateral flavum. So ipsilateral cranial V point to the midline, contralateral resection, detach the cranial, detach the caudal. And this is a typical post-op MRI. So I just show a challenging case, a 40-year-old, I mean not 40-year-old, a person with a BMI of 40. So every aspect in a patient who is obese, a bigger BMI actually is very suitable for uniportal surgery. In fact, maybe a dream for uniportal surgery, because one incision you can actually do 3 levels because there's so much mobility in the soft tissue. Probably is one of those cases when the bigger they are, the better the uniportal. So, but of course, there are other aspects of difficulties. So difficulty in the airway, epidural anesthesia is difficult, IV anesthesia, everything is difficult in an obese patient. However, I think for a lot of things, all things equal, uniportal surgery is essentially efficient for this patient. So we do X-ray check. I think for obese patient, they may impair the quality of the exposure of the radiograph. So you may need a higher concentration. And then this is the quality of X-ray. If you see that, and it will be more difficult. And then you measure the distance. Some of the, I didn't have a patient that obese that you can't use the stenosis scope to reach the lamina, but we have to think if it's a really big, but sometimes we need an extra long scope. So we have to do the pre-op planning. This is what I mean. If you have an obese patient, there's a lot of soft tissue. You can do 2 levels with same incision, maybe even 3 levels. You just have to plan your incision accordingly. So these are intraoperative challenges. In an obese patient, I make my skin fascia cut under II. Fascia cut under II, because sometimes you thought your knife is deep enough, then you realize your whole blade is in and you're still not cutting the fascia. So that's sometimes you have to do it under II. So this just some of the operative video. It shows that you can go up and down and do the 2-level decompression. And despite collimation, is zoom in and images are not very clear. Okay, this is just the video of this lady, 68-year-old, bilateral claudication, spinal stenosis of both levels, L3-4 and L4-5. So she walked about claudication distance of about less than 100 meters. So she's morbidly obese of BMI of about 42. I start with the L3-4. I think the main difference, I do both UBE and uniportal. I think for both of them are similar in terms of the higher lamina, higher lumbar region, the space can be tight. Some of them are so tight that you do not have enough space for your 13 mm outer diameter scope to enter. So you have to create enough space before your scope can enter deep enough. Even if your scope is hovering above the interlaminar space, then there will be a lot more bleeding because of the the water pressure is not sufficient at 30 mmHg to maintain the field clarity. So you try to really get down by
adequate drilling of the bony element to get down to the interlaminar space. Once you get in, the clarity of the vision is good. So we do ipsilateral laminotomy, then you can see I use a bit of kerosene to clear up the flavum. You can do drilling as well if you want to do an on-block resection. These are my earlier video done a few years ago. So this is how we did it. So I remove, in this case, I remove the ipsilateral flavum first. I think in L34. So this kind of more of a modified, inside out technique, because after I realized I removed the flavum, I realized I still have to do a bit of more bony resection. So then we have a hooded instrument like this to do drilling. So it's still safe despite the dura being exposed. Although personally, if there's a, as much as we try to do all the bony work before you do your flavum removal. Nevertheless, in this case, we remove the flavum and then we resect the SAP, then we do the L45. You can do L45 followed by L34. I don't recommend 2 incisions. One thing I would like to highlight, in uniportal, unlike biportal surgery, if you make 2 separate incisions, then you realize your water outflow flow outside, and then you do not have a contained pressure within your compartment, which is not suitable for uniportal, because uniportal have an inflow and outflow. And your visualization will be compromised in uniportal if you make too many incisions. So in an obese patient like that, it's really ideal for uniportal. You can use 1 incision and you can clear multiple levels. So the video is just showing how we can decompress the next level on the right. So we're just taking out the epidural fat now, and then decompress. At the final stage is the same UBE-wise or uniportal. You just check the ipsilateral, lateral recess, contralateral, lateral recess, and then you can check whether it's adequately decompressed. So in the concern of time, I just show you the post-op MRI. So in conclusion, this is published in my paper, the 12 steps. I think for the concern of time, my time is up. We can maybe, if you are interested, can Google this paper and read it up. It's open access. Thank you very much. And one more thing. Yeah, I'm the guest editor, as I mentioned yesterday. If you have articles that you would like to publish, please submit to Medicina, which is a PubMed index journal, impact factor 2.948. Okay, thank you very much.
Thank you. Thank you, Dr. Wu Panghung. Dr. Wu, any question?
Graft is completely packed in. I'm shutting the fluid to show you bleeding from the end plates. You can see the punctate bleeding coming from both the end plates. The graft is all packed in front here. And now you're getting ready to introduce a 12 millimeter by, put on the fluid again. It's a 12 by 24 gauge. And Dr. Seshav is now going to do a little bit of dural retraction for me to protect the dura while I put in the cage. So here he is introduced a small retractor, UV retractor. The designer of this instrument is sitting in the hall, Dr. Yunjinwa. Now I'm introducing the cage in. Can you show my hands, please? Yes, now the cage is gone in. It's floating outside the foramen. You can see the exiting nerve root. And I'm keeping a watch on it and I'm trying to engage it first into the bone. It's very tight. It's going to be extremely tight, sir. Super. And should I shave the posterior edge? That is a good issue. To create more space. Huh? Okay, let's start hammering. Let's see how it goes. And we have the cage here. We have the dural edge retracted by the dural retractor. Okay. There's the retractor. Retractor is in place here. And exiting root is here. Let's try hammering it in. Come on. Let us see how it goes. Come, hammer. Hammer. Faster. Faster. The cage is fast. No, it's still there. Come on, hammer. Yeah, I know. Go to a little more. Deeper. 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 Thank you. We'll wait and we'll take a Siam shoot now. We'll see where we are. This is the exiting route over here, nice and safe. A little bit of bleeding occurs because once you put in the cage, the eddies current set in, and there's a little bit of tissue over here. We'll be removing that later because I can't put too many things through one portal. First, I just want to see where my cage is gone. Sir, आपका हाथ हटा देना अभी. Short, please. Yes, the cage is almost at midline. And we'll now see in lateral how deep it is, and then we'll proceed banging it in further. And then we'll flip the cage to make it horizontal. Can we please have the Siam coming in lateral, please? Pass. We'll have an accident over here. Siam induced spinal injury. First known case in the history of the world. We are just waiting for the lateral, guys. Please have your patience. Yeah, sure, please. Yeah, cage is nicely gone in, but can go much deeper. So we will continue with our path. Come on, hammer it in. One more shoot, please. More, Sharwari, much more. Shoot, please. Say, shoot, tu marne yaar. Tu maar. Shoot. Shoot. Yes. Little more. Pass. Shoot. 24. Pass. I think nicely. We have to rotate the cage. You want to seat it more anteriorly? Okay. Come on. Shoot. That's better. Now we'll see Napi again. Come on. Yes, please. Yeah, you can see the. Chalo. Come on, Napi, guys, please. It's okay, I got to live with it. Don't look down. We always crowded for space, but then it's always nice to keep a little extra space so that you can see things better. You can see the exiting nerve root up here, nice and safe. You can see the dural edge over here, nice and safe. Okay, we still have to do a little flavectomy, and then you have to start with putting in the rods and screws. Dr. Bhupesh, can you come and take over the surgery? And Seshav. Okay, sorry, I've been pushed away. Shoot. Yeah, very nice. Huh? Shoot, please. Shoot, please. Thank you. Now we will be flipping this cage and making it horizontal. Okay, thank you. Can you take the Siam back for a minute? Thoda piche lena, bas zyada nahi. Can you disengage from
Hello.
me, please?
Hello, Professor Malcolm. Hello.
Hello, can you speak loudly?
Yes, I'm Dr. Nantawat. Thank you so much for a nice case insertion, Professor Malcolm.
Thank you, sir.
Yep.
Honored for a comment from you. Okay. Now I'm going to flip this cage. So I'm going to use a cage flipper. It's a normal rod. I think again that's been designed by your genius knowledge, Dr. Yumjanwa. And I'm going to put in this rod. Can you see this tip? Yeah, I'm going to put this tip this way. And then I'm going to start flipping this cage a little bit and making it horizontal. There are a few pieces of graph which I need to remove. Okay. This always happens when the cage goes in deep. Come on, now hammer this cage, please. Feature of machine. And you'll be able to see the cage becoming more and more horizontal as we hammer it in. Yeah.
Yes.
Yes, thank you. 1 minute. You can see the cage is beginning to move. Okay, it's becoming more horizontal. Hammer, please. Hammer. Hammer. 1 minute. Yes, the cage has become nice and horizontal from its original position. We'll make it a little more horizontal. Come on. Thank you, thank you, thank you. And now you can see that the cage has become nicely horizontal. I'm going to put this again on top of the cage over here so that I can press the cage down a little bit. Can you hammer this now? Hammer. Hammer. Thank you. So our cage has become quite horizontal from its previous entry. I need a little bit of this punch. And we will now proceed with a little bit of phlebectomy to decompress we have done the opposite side contralateral decompression. I'll show you that also, please. Give me 1 minute. Now the only thing that is remaining is the phlebectomy. And once that is done, I think our job is over. Thank you. All extraneous tissues removed. Can I have a small staple on this wound so that we can reduce the bleeding and have better vision? Now, what we have done is we have done a contralateral burring. You can see I've gone on the contralateral side. The whole contralateral side, the SAP, IAP has been cut. That is the opposite foramen which has been opened up. And this is the V junction. So we've done everything. Now we have to only do this little phlebectomy. And after that, put in the rods and screws. So I'm going to proceed with the little phlebectomy part of it now. Labrum is auto separated from the distraction that was formed by the cage.
Malcolm, can we go ahead with the talks, or you
Yes,
wish to be with
go
the?
ahead. Now I've just showed that we are doing the decompression part. And you can go ahead with your talks, please.
All right.
So there's no need.
So congratulations, Professor Malcolm. Okay, so we will start to the next presentation. The next presentation is from Dr. Madian Noor.
Dr. Masood.
Huh?
Yeah, Dr. Masood.
Dr. Masood from Egypt. Yeah, he will talk about the basics of decompression technique in biportal spine endoscopic.
Sir, traversing.
Hello, everybody. Good morning. My name is Dr. Mahmoud Masoud. I am from Egypt. This is my hospital, Helmiya Military Hospital. Truly, I wanted to talk about basic decompression technique in biportal spine endoscopy. But truly, I will speak more about my trip here in India for 3 months training on UBE system. This was a marvelous spine endoscopy center in Vasai, Goldenberg Hospital Spine Endoscopy Center. So first, I started with training on fluoroscopy guidance. As you know, central line, paramedian line, pointing and targeting triangulation. After that, I trained more on creation of space, how to create a space for my fluid chamber by this synchronized movement of my hand together for making working channels. Third part, I trained on soft tissue cleaning on the section by probing. RF probing I used was plasma probe, manipulating it in coagulation and cutting the powers until I clear more of soft tissue, clearing my bone. First, I do ipsilateral laminar decompression using the bear. Using the bear is a manipulative method. Controlling it is somewhat hard, but I trained it more and more through ipsilateral, then going through the base of the spinous process, using cutting a bear or diamond bear. Then I become going to the contralateral decompression, wound decompression. Fifth part was the ipsilateral ligamentum flavum decompression using the caissons. Truly using the caissons, especially in the ipsilateral, then the contralateral part become more and more difficult. On training, I become more and more efficient enough to do ICLIF, interlaminar contralateral endoscopic laminoframinotomy. At the end of the 3 months, I become more trained. Of these 30 cases, I found myself doing well. My cases was very good, really. Their visual analog scale was very good post-operative. McNabb was excellent. Even disability indexing become more and more good. But I found a more complication. Just I was start my training, so I faced my complication. 7 cases with dysphagia, especially after ICLIF, but thank God it resolved spontaneously 2 or 3 weeks. But I found 1 case with dural puncture, but thank God again it is treated conservatively and gone well. So my take-home message will be very concise. UBE truly is a safe, rapid, anatomically oriented like microscope and open, less blood loss, less post-operative pain, rapid rehabilitation with preservation of stability. In conclusion, UBE technique is giving a better, easier visualization, an anatomic view of the surgery, and an alternative minimal invasive procedure treatment for all degenerative spine disease. Great thanks. I will ask for Dr. Malcolm, but he's in the surgery. At the end of that, I want to truly to thank my teacher, Dr. Malcolm Bistonji, as the Indian way I touch his feet, for learning me all these concepts, providing this great box. It is a pillar for spine endoscopy in transforaminal and interlaminar, treating me truly as one of his family, giving me this great opportunity to be part of this worldwide event. Thank you so much.
Any question from the floor?
Thank you for your wonderful presentation,
Thank
Dr.
you.
Mesut. It's I'm be happy when you see the the young UB surgeons.
Thank you so much.
Just one question for you.
Of course.
Do you have any criteria to think, yes, I finished the decompression completely?
Criteria?
When you decide to the decompression finished?
Yes. My decision, my decision always seeing is a traversing route, freely moving. clearing all the ligamentum flavum surround. So this is the criteria I know until now. It is improving so much, but really I want to see my traversing and extending nerve root very decompressed, moving, nothing compressing it in its movement, especially under saline irrigation. Thank you so much.
Okay. Thank you so much.
Well done, Masood. Thank you.
And the next speaker is Dr. Khalid Murad. Yes, Khalid Murad from Iraq. And he will talk about modified endoscopic discectomy, a new approach. Please, Professor.
This is not good.
Hello, everybody. First of all, I would like to give great thanks for Dr. Malcolm and Dr. Sameh for this and their team, nice team, for this generous invitation and give a chance to me to sharing experience and information with a great teacher. Thank you. My talk is about modified transforaminal endoscopic discotomy. It is a new approach, simple new approach, especially for cases of recurrent disc herniation for L5S1. As we know, there is a risk of reherniation. It is ranging from 0.5 to 25. Some centers said it's about from 5 to 18. Also, for endoscopic discotomy, there is also a percent of reherniation. Maybe it's a little bit ranging from 3.6% to 4.2 in interlaminar PLD. It's also depend on many factors like the age, increase the age, increase the weight, and also high level of vertebral disc herniation, more rate of herniation more than the lower level. Also the migrated disc, lateral disc, many factors also affect the herniation, obesity, smoking, male gender, diabetes, weightlifting, and the size of annular tear and type of primary operation also cause the more herniation. Reoperation other than recurrent disc herniation, the same level as we know, any maybe new disc in another level, herniation of different level, epidural fibrosis, adhesive arachnoiditis, and spinal stenosis, segmental instability, all of these cause to reoperation. Many societies talk about this subject, which is the solution, which is the best solution. Really, most of them, no evidence, full evidence, sufficient evidence, which is the procedure is better. Is it discectomy alone or discectomy with diffusion? It is depend on the experience of the surgeon. What you are expert, you can do the solution. But generally speaking, discectomy only if there is radicular pain, but discectomy with diffusion if there is instability, if there is a degenerative disc disease or spinal pain, so you need to do a fusion. Prognosis mostly any revision surgery has not very well prognosis because a lot of pain and work return. Also, there's complication of dural tear and instability because you will take a much amount of facet joint. So this is the complication. For endoscopy, it is preferable to do endoscopy, whether transforaminal or interlaminar PLD for recurrent disc herniation. It is best choice, better than open or surgical approach. As we know, the transforaminal PLD is preferable and superior to interlaminar, as it because you go direct to the pathology, less ligamentum flavum work, and there is no fibrous adhesion after that. And so the interlaminar, but there is, of course, there is limitation for transforaminal and transforaminal endoscopy, PLD. It is not possible to L5S1 with high iliac crest and with the caudal or cephalic migrated disc. It is good for the extruded disc in subligamentous and in the foraminal herniation. So revision surgery, endoscopic surgery for recurrent disc herniation, transforaminal is the best. It is superior to the interlaminar PLD. This indication, I mentioned that. There is a contraindication like instability, infection, bleeding tendency, and systemic disease which prevent upon position surgery. Home message, transforaminal and interlaminar PLD is the safe and effective surgical option for recurrent disc herniation after previous surgery. Transforaminal approach of PLD is safe and better because of use, not need to expose the scar tissue of a previous surgery. Procedure and operation time is similar. Previous PLD, transforaminal, significant improvement. This is a photo. First of all, the technique, modified technique. It is like a pain management technique, like enter the disc and intradiscal injection. Really, my opinion is to start with conservative therapy and pain management after each recurrent disc herniation, before you are going to do endoscopy or revision surgery. Just pain management, injection, transforaminal, or adhesiolysis, it can give a very good result. I have many patients. I give them injection, simple injection. I improve very well. So in this technique, we keep the pathology on the contralateral side, and look, show the disc. This is the disc after gate angle. Because why put in the contralateral side? Because the C-arm opening angle is you can get about 35 to 40 angle of the C-arm. Look, in the same way, I think we can adopt this technique for high thoracic vertebral endoscopy. My colleague mentioned that you can depend on MRI reading to measurement the distance from the anterior point to the disc. So we can adopt this technique for the lower thoracic vertebral endoscopy. And by measuring, it looks like the same, 6 to 8 centimeter, the anterior point to the middle of the disc. It looks like this. So at the end, you can the target, the docking point on landing point is it is SAP at the base of SAP. It is safe. It is safe. The landing point of the needle. Now I can show. After this, I can show a video. Where's the video, please? Yeah. عملية استئصال انزلاق الغضروف بالناظور تقنية حديثة. Look, the distance is about 6 to 8 centimeter. and the angle is more than 50 centigrade, and you can reach easily to the foramen. You can use also a grasper, which is angulated grasper, and you can take a good bite disc by this procedure. I did more than 50 cases. I get a very good result. And no need to do rough endoscopy like transiliac or the iliac. It is easy, and it is a very bloodless field. You see, it is a bloodless field, and it's short procedure. And we can also, as I said, we can use it. You can intradiscal approach or modified approach to the lower thoracic vertebral endoscopy. I have also, this is okay. I have also a quiz. Complete the lecture. Completed. No. Yes, I have a quiz. The winner will get a ticket, free ticket and the accommodation to Babylon, oldest historical city in Iraq. But don't afraid, it is not one-way ticket, it's by-way ticket. Okay. I did the PLD, interlaminar PLD. Make it big. I found this structure after PLD, after the photo. Yes. I found this structure after removal of ligamentum flavum, after removal of ligamentum flavum, and removal of part of facet joint, and the upper lamina. This is the upper lamina. I got this structure. Both of this, it is pulsatile structure. I usually got the traversing nerve root, but I got this structure. I need your opinion, really. I need your, you are great teachers and my teachers. So what's, anyone can give me the opinion, what is the type of this both structures? And who will get a free ticket? Yeah. I also, show me the video. I will show you the video of this. This is the photo. Video, there is a video. No, not this video. Another.
No, don't do it. I wanted to, he should show the MRI first. Which level is this? Which side is this?
Yes. Another. No, another video. No, the video is the same lecture, in the same lecture. Show me the same lecture. Yes. Yes, another one. Yes, this is the video. Oh. This is the video of this case. Really, I just make a decompression and took a lateral dissection of the facet joint, and I didn't do anything. This is both of this pulsatile. It looks like nerve tissue.
Can you show us the MRI?
Sorry, MRI. I didn't get MRI for this. I forget to introduce in. I will send it to you later.
Neurolemoma.
I don't know. Thank you very much. The lecture is finished. maybe congenital anomaly of nerve root. Maybe this one option, one opinion. No, I will get.
I've seen image. I don't need the ticket. I think it's a neuroma. I've seen a similar picture. Basically, schwannoma.
Usually it is a
one or two.
neurolemoma because it is intraneural.
Schwannoma?
Schwannoma will be outside the nerve.
Yeah,
root.
probably.
So
One of
if
these.
there is more
Neural-
opinion with him, so he will win a ticket.
Yeah, I think it's Dr. Robinda.
Because I have a similar case I mentioned in my book. It was right-sided L5S1 thickened nerve root. I informed the patient's relative, called them inside, and then opened that, removed that neurolemoma, and patient was quite well preserved.
Yeah,
It is mentioned in my book.
I think if I don't misunderstand,
Please open
you
the-
say
the
that in the endoscopic discectomy, the is not developed the fibrotic tissue. Is it true?
Yes, really, I mean monoportal endoscopy and the transforaminal endoscopic discotomy never caused a fibrosis, fibrous scar tissue. Even you can do transforaminal endoscopic discotomy in the same level after a few months, a few years. I think it is
So
not.
which technique you use?
But I'm not interlaminar may cause scar and adhesion fibrosis. But for transforaminal, because you are less dealing with the ligamentum flavum and soft tissue, so I think it is not so much
No, I'm
facing
not
with this
agree with you.
problem.
The other thing is I saw that your the portal point is very far from the midline, and also your angulation is almost vertical. So how can reach to the
Yeah,
near
yes.
foraminal disc with this
Yes, it looks like when you get to the lower part of iceberg, you eat from the disc and slowly up until you reach to the posterior longitudinal postipialar.
You're passing the facet joint.
Yes, you face the facet joint and can take from passage foraminally. Mostly you are docking point on the foraminal side.
You did that the same approach as me. We docking on the SAP first. Yeah. Yeah. But the approach is dock to the SAP first, right? Identify the SAP and cut the lateral part of SAP as you need, right? And then follow to the pedicle, and you will find the disc in the foraminal area.
I think yesterday my colleague from US and from India present a case for lower upper thoracic vertebral endoscopy. I think it's look like the same approach. It is transforaminal approach, and the docking point and landing point is lower part of SAP, and from that you can go to the disc.
About the scar after any surgery, it is a natural tendency to heal with a scar. If you do a recurrence, whether it is transforaminal or interlaminar, and you are able to do it, you say that the scar, there was no scar. And if you land in problem, you think that it is a very thick adherent scar. So it is personal. Body has to heal with scar. Whether it is any technique, it doesn't matter. It's a natural process of stabilization. The osteophytes are also auto-stabilizing natural process. Yeah.
Thank you very much.
We now go to the session 5. Can I call upon Dr. Seong Bong Jung from South Korea? He will talk on how to do biportal endoscopic foraminotomy and discectomy. Your next topic after this. Yeah. All right.
Hi, hello, I'm Seokbong-jung, orthopedic surgeon in Jinju Boden Hospital, South Korea. Thank you for inviting me at this symposium. What I like to talk about the bipolar endoscopic foraminotomy and discectomy in cervical disease and technique. I'm an orthopedic surgeon in Korea AO Spine delegate and a member of MIS and a member of COSAS. My 4 SCI journal is related to biportal endoscopic surgery. Next Thursday evening, I will give a lecture about 4 and 5 endoscopic lumbar interbody fusion in AO Spine International June seminar. Why cervical biportal? We have been operating ACDF, open foraminotomy, tubular retractor, and one portal endoscopic surgery in cervical disc herniation and foraminal stenosis. Endoscopic biportal surgery is 2 portal, viewing portal and walking portal, so we can use both hand freely and independently. Many biportal surgeons use 0-degree scopes, but I strongly recommend the 30-degree scope because it's wider view. Left one is 0-degree scope, right one is 30-degree scope at the same patient after decompression surgery. Ipsilateral side, contralateral side. This following picture shows the various open surgical methods in cervical disorder. The last 2 surgeries has been replaced by biportal surgery. So I rarely done nowadays. I performed the biportal surgery from 2015, 2021, about 2,400 segments. And cervical disorder is 172. Largest share is C56. In terms of surgical technique, the ideal instance between viewing portal and walking portal is 2 to 3 centimeter. After scope insertion, find the viewpoint between upper lamina and the lower lamina, and the water pressure and the outflow of water be well balanced, so you can secure a clear view. Incision site is transverse skin incision, proximal is viewing and distal is walking, and dissect with the straight mosquito, dissect the muscle, and the triangulation technique is double-ended separator. Upper one corner is after 2 months surgery scar. I took a video for your better understanding. Laminotomy with ball. This article is excerpted from the Tanaka's article in Spine Journal. The anatomy is relation between the nerve root and the disc. A is when the disc is proximal to the nerve root. The C45 disc is anterior to the C5 root. This picture shows the moment of which the disc is being removed from the axilla of left C7 root. And the picture below, it shows depressurized C8 root after the removal of disc. Over 170 segments, 140 segments have only foraminotomy, and 32 have foraminotomy and discectomy. Average operation time is 38 minutes. This shows the result of foraminotomy in foraminal stenosis and discectomy. It demonstrates
higher level of medial facetectomy in cases of foraminal stenosis. 46 female patient left scapula fine. The picture below is post-operative. This video is remove the flavum. This is annulus. Cut the annulus with sharp probe. And okay. Probing, check the up and lower and disc space. Next one. 59 female patient is he had underwent artificial disc surgery 7 years ago, but he has low level rupture disc. The picture below is decompression and discectomy. This patient left hand is working, probing and the palpation and the rupture disc. Rupture disc is removed. Is removing the large fragment in C67. Another fragment. Remove the disc. In one side, C34 OPL, we do decompression foraminotomy and partial laminectomy by biportal technique. In far lateral foraminal disc herniation on C67, you can do this by biportal technique. I carried out this surgery 4 days ago before I come to Mumbai. 80-year-old female patient. In the MRI, you can see the mesh-like lesion C2, 3. In the CT scan, calcified mesh, you can see the on the C2, 3 level. The patient has quadriparesis started 3 weeks ago. I think C2, 3 intradural extramedullary tumor. Tear incision and dural remove the mass. Post-operative MRI, you can see the sufficient decompression, but even though we can see the a small remnant of the adhered dura, small mass of the adhered dura, but we can sufficient decompress overall, and we needed to, for this surgery, we needed 3 portal, viewing portal and 2 working portal. I have no the result of biopsy has not come out because for 4 days ago I carried out surgery. Right one is mesh material. The patient have improved next day 30 to 40%. Results are usually excellent. I think this surgery would be a good surgical technique for surgery, the cervical herniated disorder. Thank you for your attention.
Yeah, any questions for Dr. Jung?
cervical dura is so thick. So I use sharp probe and tear the longitudinally, tear the dura longitudinally. Yeah. How close? I stitch up with stitch up directly with 6.0 or 7.0 nylon. So cervical dura is so thick and very tight, so you can stitch up easily.
No. In last case, you showed the interdural tumor.
I think I assume it is meningioma.
It's okay. No, it's an interdural tumor. So you open the dura and you still use the fluid medium under pressure.
Sorry?
You did the interdural tumor. For that, you have to open the dura.
I have no experience about that.
So I will answer your question. Okay. Actually, we don't recommend this case, intradural extramedullary tumor case, because you're right. Okay.
The
water
fluid-
pressure, fluid go
it
into
is
the
going to
brain.
go into
I
the
think
CNS.
I think it's not possible
Yeah.
to the surgery
We can-
intradural tumor.
Yeah. But in Korea, some surgeons try to remove intradural mass with bipolar endoscopic surgery, but actually I don't recommend.
No, but how they do it then when they use the fluid medium?
Yeah, fluid medium, there is sometimes no problem because the fluid going in, going out is very fast. Don't go the fluid into the brain usually, but sometimes go into the brain.
You cannot direct the fluid that it should go from this end and go from that end.
No,
It has its places inside.
No. So fortunately, that happen easily.
And that's what.
So we can do our surgery in the endoscopically, but it is not easy. So I don't recommend.
Sometimes old age is lumbar dura is so tear easily during the stitching up, but cervical dura is so tight and so thick. So you can if you can exercise for a long time, you can do that easily.
I can do interdural tumors. There is no problem. The highest level I have done is the C2. And you can do it. Patients are mobilized after 2 to 4 hours, no catheter, no drain. So that is the advantage of endoscopy. Endoscopy, interdural tumor, interdural extramedullary tumor is just like a canal decompression. You go from one side, undercut the opposite lamina, expose the whole cord. You are cutting the dura, you take a dural stitch, and then you can remove the. I close the dura with anasto clips, which are 2 mm titanium clips which are used in cardiothoracic surgery, and the dural closure is within 1 minute.
Yeah.
Watertight closure.
Yeah, but I think I need the two portal. It is impossible to do surgery. But
because your one port is having the endoscope and your one hand is holding the scope. It is a one-hand technique.
Right.
For interdural tumors, you need 2 hands. That's why it is a 3-port.
Yes.
Yeah, I know. I understand.
Thank you, Dr. Jung. That was a wonderful presentation.
Yeah, thank you.
So now I call upon, now I call Dr. Hayati to give his presentation on endoscopic stabilization.
इधर है क्या?
It should be. Yeah, this is the latest. It's not working. We can change with my cable basın. First of all, I want to thanks to organizing committee and Dr. Malcolm Pastonji for their kind invitation. And I'm very happy to be here again. And I'm happy again to see very interesting lectures and the presentations. The colleague, my presentation will be about the endoscopic stabilization. Yeah. As a definition, you know, the endoscopic stabilization means that stabilization of the functional segments by using surgical techniques. We have two different types of endoscopic stabilization. Non-instrumented, which is can be done by the bone grafting and the external immobilization, and the instrumented fusion. We have many different techniques for instrumented fusions. Open surgeries, minimal invasive techniques, and endoscopic techniques, which is developing day by day. We heard about different endoscopic stabilization techniques. Indication for endoscopic stabilization is almost same with the minimal invasive surgery. The listhesis, except higher grades, and the traumatic instabilities, pars fractures, iatrogenic instabilities. If it is necessary for the revision surgeries and some mild deformities, and also some painful conditions because of facet joint arthritis or degenerative disc, painful degenerative disc problems. We have some contraindications, of course. High-grade spondylolisthesis is not available for the endoscopic stabilization for now. Uncontrolled infections, another contraindications, and of course, severe deformities and the primary tumors, especially for the fluid medium endoscopic techniques. The infections and the primary tumors are the contraindications. And if you have some severe global alignment problems, it's the endoscopically maybe correction is not possible. So we have mainly two components of the endoscopic stabilization surgery. One is endoscopic cage insertion after decompression. Then the percutaneous posterior stabilization. And you see the surgical sequences of the endoscopic stabilization and the percutaneous posterior instrumentation. Those sequences are very, very important for the successful stabilization. You know, mainly we have two different approaches in unilateral biportal endoscopy, paravertebral and the paramedian. Also, this same for the stabilization method, paravertebral or paracentral and the paramedian or paravertebral approaches is possible. For paramedian, you see here, we are using the standard UV surgery methods. Preparation, defining the midline, lateral wall, target levels, and the opening the portals, then starting the surgery. Let's talk on the live surgery, the posterior endoscopic stabilization. This case was suffering from severe low back pain, walking difficulties, and also she had the decompensation posture. Now you see here, because of the clinic and the MRI, we decided to the surgery. But when we see the dynamic radiology, then we decided to make a stabilization. Okay. Okay. In stabilization, the decompression is, of course, same with the endoscopic technique. When you finish the decompression, then we doing some facetectomy to gain more space for cage, and also to get some bony grafts is the good way to get bony graft. After then you see the disc level. Then we started the discectomy. Here's the nerve root. Starting the discectomy as possible as lateral is important actually. You can put a long cage. Also, to make rotation will be very easy. I'm using like this discectomy drill to make faster the surgery. Then after discectomy, we should put some trials to decide the then put in the cage. The cage size should be accordingly with the trials. I always prefer the long. Mostly I'm using the 36, 40 millimeter cages. Putting big cage is not actually not adding some additional benefit. Then you see here the rotation of the cage. This was the posterior cage insertion in UBE surgery. Then I think finish. And of course, we should add the posterior stabilization with the percutaneous screw. Then first you should define the pedicle, then Jamshidi needle insertion, KY insertion, serial dilations, and tapering, and the screw placement. And always you should adjust the patient position before the rod insertion to get lumbar alignment, and percutaneous rod placement. Then you need some compression and the result. Yes, you can do more levels. Now let's see the transforaminal. Again, the preparation is same with the paravertebral UBE approach. The portals and the working space preparations for aminotomy, discectomy, end plate preparations, and the grafting. Then cage insertion and peritoneal instrumentations are the sequences of the transforaminal interbody fusion. This case was very young. She had severe low back pain. Before then MRI, let's see the video again. This is a paravertebral approach of the UBE. Here's the nerve root, you see. This is the disc level. After removing the SAP, then you can see the foramen very clearly. You see the end plate preparation. Again, we should put the trials to decide the size of the cage. Then insert the long cage again. If you prepare the good
Nectar is not.
Dr. Punit, have you mounted your open your talk? Can you open it and Dr. Redas, he can give? You're open? You're open? Yeah. We now call upon Dr. Punit Gulati till Dr. Redas fixes his talk to talk on pain generators in the lumbar spine. Kindly stick to the time as
Yes,
we are running behind very much.
Good afternoon, everybody. A very big thank you to Malcolm sir for extending this invitation to me. I am Dr. Puneet Gulati. I am a neurosurgeon based in Delhi. I'll be talking about pain generators in lumbar spine. So starting with what is a pain generator? A pain generator is a pathological structure from which the primary cause of the patient's low back pain or radicular pain is thought to originate. It is the primary or the sole cause of the patient's illness. And our basic aim, especially in endoscopic surgery, is to identify it properly so that we can target the treatment. Now, in the era of open surgery, we used to just remove everything inside. But endoscopic surgery or any minimal access surgery, our aim is now a targeted treatment, identify the pain generator correctly, and target it to relieve the patient of the symptoms. So what are the pain generators in lumbar spine? Disc, facet joint, the sacroiliac joint, the nerve root can be the pain generator, the spinal muscle, myofascial pain, spinal ligaments, particularly ALL, PLL. The lumbar intervertebral disc, starting with disc, comprises of the cartilaginous end plate, the annulus fibrosus, and the nucleus pulposus. Now, the cartilaginous end plate is a 1 mm thin structure, and this can fracture during acute traumatic loading. Mostly it starts with an acute event, but gradual flattening due to disc degeneration can also occur. There can be formation of a Schmall's nodule. This occurs in patients less than 50 years of age. And this is due to the herniation of the nuclear material into the vertebral body. As we can see in this diagram, the MRI picture also shows the same. This node represents a breach in the integrity of the end plate. So now they are generally asymptomatic, but can sometimes be symptomatic. The injury, as I said, occurs to a macrotraumatic event. The pain, acute pain, is short in duration, and generally this is limited to the central low back region. It resolves in 4 to 6 days. After this, over a period of time, the node becomes chronic. This takes several years. Chronic nodes, again, they are mostly painless, but they can become painful if an inflammatory cascade is triggered in the vertebral body, as the nuclear material comes in contact with the blood. Now, the nucleus is hermetically sealed in normal cases. So when it comes in contact with the blood, it almost acts as like a foreign body, initiating a chemical reaction against it. This chemical cascade then leads to chronic pain. The character of the pain in this case, this is a gradual onset of band form distribution of low back pain and non-radicular lower extremity pain. Now, this chronic pain generally occurs over the age of 45 years of age, and compared to the immediate lower extremity pain in younger individuals who suffer from acute disc disease, in that cases, the pain is due to irritation of mechanical irritation of the DRG. And this pain, that pain is radicular. The pain due to the irritation of DRG is radicular pain. This pain is non-radicular. That is the difference between these two. Now, the annulus fibrosis and nucleus pulposus disc is 70 to 80% aqueous and is composed of an outer annulus and inner nucleus, as we all know. Axial loading and repeated microtrauma can lead to annular tears with the nuclear fragment trapped in the tear. This can become a chronic non-healing tear with neovascularization and inflammation. As the schematic diagram shows, there is a gradual degeneration of the nucleus. Initially, there is a chemical cascade only, but as the fragment becomes trapped, besides this chemical cascade, there is a mechanical irritation also. And this causes this discogenic back pain. This annular tear leads to the initiation of this cascade. Now, discogenic back pain is central, either horizontal or vertical. In patients with good annular integrity, the pain reduces on extension in prone position. This forms the basis of the McKenzie test, which we all do in our clinics. This disc outline does not change significantly on MRI. High intensity zone on MRI. HIZ on MRI has a high correlation with discogenic pain. However, it can also be asymptomatic. Now, to identify whether this annular tear is the one which is actually causing the patient's low back pain, a discography is a very sensitive and specific test. I'll take this up in my talk tomorrow. Coming to nerve root as a pain generator, this causes radicular pain. This radicular pain is evoked by ectopic discharges emanating from the inflamed root or its ganglion. The pain radiates from the back or buttock in a dermatomal distribution. Annular tears and disc herniation are the most common cause of radicular pain. Now, annular tears leak inflammatory mediators and cause chemical irritation and inflammation around the adjoining nerve root or DRG. In disc herniation, inflammation of the affected nerve rather than the mechanical compression is the most common pathophysiological process. This is the diagrammatic representation of the dermatomal distribution of the pain. Now, next we come to lumbar canal stenosis. This is the most common cause of radicular pain in age more than 60 years. Disc herniation, thickening of the ligaments, and hypertrophy of the articular processes leads to canal stenosis. By definition, canal less than 10 mm diameter we call stenosis. Frequent symptoms are midline back pain, radiculopathy, neurogenic claudication, paresthesias, and sometimes motor weakness. In case of central stenosis, the pain is bilateral and non-dermatomal. Lateral recess stenosis, the pain is dermatomal, resembling radicular pain. Now, facet joint is as a pain generator. This is another one we commonly come across. The pain is paraspinal, well localized, and increases on extension. Rotation of spine, lateral bending, and walking uphill also causes this pain, climbing stairs for that matter. Commonly, this is bilateral. Age is more than 60 years generally. The pain may be referred to the legs terminating above the knee, often radiating to the thighs or the groin. There is no radicular pattern as such. It is exacerbated on waking up from bed or like many patients tell us on standing up from sitting down position. The inflamed facet joint and the distribution of the pain in a schematic diagram. So the test we perform in our clinics, we are familiar with this facet loading test. The patient is made to extend, lateral bend, and rotate, and this typically reproduces the pain. And quite often there is tenderness also at that point. Sacroiliac joint as a pain generator. This is a sharp stabbing pain that most frequently presents in the buttocks. The pain may radiate up to the lower back and down to the thighs. This pain can be aggravated by prolonged sitting, standing on one leg, stair climbing, again going from sitting to standing. Diagnostic injection is the only confirmatory test. And in a young patient, always rule out Angspont, particularly bilateral pain. Faber test we use for diagnosis. Again, we do this regularly in the clinics. The hip is put in flexion, abduction, external rotation. Then the flexed knee is pressed down towards the table, and the typical pain is reproduced with this maneuver. Bertolotti syndrome, not very common, but still we come across these cases. Transverse process of L5 is elongated and fused with the sacrum. This places stress on the L4, L5 joints above, even up to L3, L4 can also be under stress, and the SI joint below. Basically, this is a pseudo joint which is formed and then leads to adjacent segment degeneration. This causes persistent low back pain that radiates to the buttocks. An X-ray picture showing this. Myofascial pain, muscles, fascia, ligaments, they can also be pain generators. Muscles that can potentially contribute to the pain include generally the quadratus lumborum, iliopsoas. These two are the most important, but also the deep intrinsic muscles and the more superficial erector spinae, they can also be involved. Now, the myofascial pain might result from overuse, acute stretch injuries or tears, and can be diffused or localized trigger point pains. A trigger point is an area of the body that may produce pain when stimulated. They are made up of stressed or injured muscles that cause pain and tightness. Symptoms worsen with activity and are relieved with rest. Piriformis syndrome, another sometimes missed pain generator. The piriformis muscle can sometimes press the sciatic nerve. This causes pain, tingling, and numbness in the buttock. Generally, the pain is restricted to the buttock. There is a difference between the discogenic pain. This is how we differentiate clinically, because radiation down the leg is rare, but yeah, it can occur. It's not like it can never happen, but it is generally rare. The piriformis test, the FAIR test, flexion, adduction, internal rotation, the patient lying side down, sideways. We put the hip in around 60-degree flexion, the knee 90-degree flexion, and then the knee is pressed down towards the table. This reproduces the pain the patient is having. Now, ligaments, I think I have crossed my time limit. The ligaments can also be pain generators, PLL, ALL. I think I'll stop here. Thank you.
Thank you. Dr. Rohidas, you are reading? Yeah. For want of time, we won't have questions. Sorry, Dr. Gulati. Thank you for a lovely presentation.
Thank you.
So this is before lunch. So just let me know when I have to stop.
You may go on. Go.
Before lunch, it's very good to have a lecture because there is no time limit. So I just wanted to talk about how to incorporate endoscopic spine surgery in practice. This is for the young people in India. You have to choose that technique. I'm not against any technique, or I'm not for any technique. You have to understand each and every technique, physics, the economics, and then you have to decide. So you have to work on that subject which others have not worked on it. Suppose there is a new technique, you have to learn that, focus on it, do it persistently. Don't change from one technique to another, and let the others know about it. You have to present your work honestly with your videos. So your recording system has to be very good. What you are doing in your OT has to be presentable in that particular format to the others. These are the two things you have to understand. In the morning, I told you, minimally invasive spine surgery, MISs, they are maximally invasive because we are not compromising any goal, just like laparoscopy. We are using laparoscope, but we are able to do each and everything, like Whipple's also. Now, endoscopic spine surgery doesn't matter if the results are going to be same after 2 or 10 years. Patient wants immediate results, immediate post-op. His immediate post-op pain has to be significantly less as compared to his pre-op pain. His paresthesia has to be significantly less as compared to his paresthesia before surgery in cases of canal stenosis. Then he is happy. So we have to minimize the collateral damage, reevaluate our current thinking, generous use of endoscope. Endoscope is a tool, which technique doesn't matter. Always remember keyhole or MISS, endoscopic spine surgery refers to concept, not the size of incision. You have to understand that concept. And the latest technology will help you in creating the brand value or latest techniques. So what you need for endoscopic spine surgery, you need endoscope, you need a tubular retractor to retract the muscle with minimal trauma to the muscle while exposing the lamina. You need endoscopic instruments. According to the type of the tubular retractor, what you are using it, whether it is mobile, fixed. You need medium to expose the operative area, whether it can be air and fluid. You have to learn appreciation of depth with the 2D endoscope in that panoramic vision. This is one of the key things you have to learn. Now, this tubular retractor has started in 1977 when Casper thought of using this tubular retractor with microscope. This is a tubular retractor, fixed one. This is the cheapest tubular retractor. This is a thoracotor used in laparoscopic surgery. You can have a 0 degree or 30 degree scope. You have that sheath and a scope holder. Nothing, all the instruments are routine one. This is the cheapest model. This is by Dr. Joe, HD Joe. So when you are starting about the decision about the endoscopic spine surgery, what are the things you have to think about? The skin incision, whether you want to do it under local or general anesthesia, the cost of the instruments, what type of endoscope you are going to use, the mobility of the endoscope, endoscopic exposure at the site of the pathology. That is very important. Whether you want to use dry or wet technique. This is one of the thing which I have not understood, whether it is a pre-endoscope, pure endoscopic or endoscopic assisted. When the instruments go parallel to each other, it is pure. When it is the instrument go through the separate ports, it is endoscopic assisted. But the easy-go system or matrix, the instruments and the scope were parallel to each other. Versatility of the technique, learning curve about that technique, and how you will be able to avoid those complications. If you are master, how you can modify the technique, that is the last thing you can achieve. Same thing. Now, when I started, there was interlaminar approach and foraminal approach. So it is air-based and fluid-based. Foraminal approach was yes system. Interlaminar approach were distant use technique, and at that time it was metric system, and now it is easy go. Then the other people came and interlaminar fluid-based technique came, like a single port stenoscope. If you compare the size of the outer sheath of the stenoscope, it is same like a small matrix tube, tubular retractor, or the distant use smart system, or you can compare with the Mohinder Kaushal system with that tube. Now it is interlaminar fluid-based unilateral biportal. Now it depends upon your neurosurgeon or orthopedic surgeon. If you are orthopedic surgeon, you are very well. If you are very well trained with arthroscopy training, with the mobile movement of the endoscope in the arthroscopy, then you will be able to learn this UBE or stenoscopic technique quite easily, because you are technically know how to use that endoscope. For a neurosurgeon, we use microscope. So that is a fixed vision. So mobile vision disturbs a little bit in the initial stages. That's why the learning curve is a little more. Other important thing is whether it is your own hospital setup or you are working in the multi-specialty setup. That also is important, because everything comes about the cost. All the distant view technique who have done ample number of cases, we all have our own hospital. That's why we could survive and we can learn, because it's our own hospital. That was the advantage. Suppose I would have been in a government hospital where my boss doesn't want to allow me to do that technique, I will not be able to learn that. Whether it is an insurance setup or a government setup, where the cost of the technique, the per patient is important. Now, in endoscope, you have to learn about the size of the endoscope and the angle of the endoscope, whether it is at 0 degree or 20 degree or 30 degree. When the instruments and the endoscope go parallel to each other, you have to use angled endoscope. You cannot use a 0-degree endoscope. When the size of the endoscope becomes small, when it is a smaller endoscope, you have to use long instruments. Then the instruments are delicate. The breakage of the instruments is quite often. When it is a small endoscope, depth appreciation, because the exposed area is small, depth appreciation and tissue differentiation is difficult. When it is a fluid medium, you have to use fluid and RF or laser for hemostasis. And the recurrent cost of that is you have to think of when you want to learn that technique. This is in 2002 by John Chu. This is the working port, and this is the channel for the endoscope, which is fixed here. If you now break this, this is UB. This was by John Chu. But as this was fixed one, if you lose your target, if your target is not correct, you are not able to use the technique. This is same Dr. Mazhar Hussain from India. He had thought of this. He has used this speculum, and there is a channel for the endoscope. This was he thought of it in 2005. Now this is distando technique. One hand suction, one hand is the instrument. This is a mobile one. The John Chu was the fixed one. If you break this, this is UB again. It is like this. If you break this stream, have two incisions, it is UB. This is a fixed tubular retractor. The 16 mm dilator for a simple disc, lateral disc, which is quite enough. Some people are using 10 mm dilator also. This is with the metric system, multiple tubes, multiple instruments. You can use microscope with the tubes. This is by Maxmore. They have 7 sets, one for transforaminal, one for interlaminar, other is for cervical, intradiscal, biportal, facet joint, and fusion. If your economics allows you, you can have different sets, doesn't matter. Each technique, different set. So we'll go to the skin incision. You have to think whether the size of the incision in millimeters matters the final outcome or not. One should not consider the incision size while choosing the technique one who wants to choose. A smaller incision, you have to use delicate instruments, smaller endoscope, limited vision, and less mobility. This is the incision of interlaminar and transforaminal. So don't compare the incision in millimeters. What surgeon wants to do at the site of the pathology, what is the exposure, that is very important, because that is going to give you the result, not the skin incision. This is in UB again, 2 incisions. If you see, this is a UBE. We are dissecting the muscle. So I haven't found any paper where the muscle trauma with the fluid technique, muscle trauma with the air technique, how to compare that muscle trauma. I haven't learned, I haven't thought of any method, or I haven't gone through any paper which will definitely tell how much is the muscle trauma in that particular technique. This is, you're putting the instrument, you're traumatizing the muscle. Only thing is the patient's postoperative pain has to be significantly less as compared to his preoperative pain. Then the patient is happy. This is what I understood in last 20 years. Whether you want to do it under local analgesia or general anesthesia. Local analgesia has a role in all types of spinal pathology treatment. Is local analgesia technique compulsion or a real necessity? You have to understand. GA by good anesthetist, patient can be mobilized early. Now this is the video. Let me. Yeah, this is a case of an intradural tumor 2 hours after the surgery. It's not. This is after 2 hours. Patient is not catheterized, no drain, nothing. So your anesthetic is quite good. You will be able to mobilize patient quite early. Now this is the cost of the instrument. This is the distance you set, very few instruments. These are the only two important instruments in the distance set. This is the outer tube and the inner tube. The rest you can manipulate and you can use from your routine instruments. You have to think of a recurrent cost of instruments if the instruments are delicate. RF probe, laser, endoscopic long, small tip drills, there is a recurrent cost. When there is a small incision, smaller delicate instrument, breakage is expected. It is not related to any company or something like that. These things cannot be repaired locally. So it is a recurring cost. This is again the same slide, multiple instruments. It's the cost of the instrument. Now in this stand, we use 4 mm diameter scope, 0 degree, 18 centimeter. In fixed system, you have to use the angled scope. So you have to be very, very well versed with the anatomy with a 30 degree scope or a 20 degree scope. It is not the same as what we are seeing with the 0 degree. Small size endoscope, limited vision, instruments go parallel to endoscope, and these are the delicate instruments. So you have a limited exposure. This is the mobility of the endospine. You can move in all directions. Now we have to think of exposure at the site of the pathology. The incision is small, smaller endoscope, limited exposure. Wider exposure. Now they are going for an interlaminar approach with a wider sheath where they can use 2 mm or 3 mm Kerrison punch. So they have increased the size of the sheath. So that is a necessity. To have a wide exposure, you have to increase the size of the incision. Wet or dry. Wet is necessary for good vision in smaller endoscope with the smaller endoscope to create pressure so that you get hemostasis and it pushes the dura anteriorly. So fluid is helping you two ways. It is giving you hemostasis and it is working as a retractor. It is retracting the dura and pushing the dura and giving you more space. Now wet has limitation to treat dural tears. Sometimes in the initial stages, you have to convert it into open wet when it is a tear. In dry method, the problem is the muscle intruding inside, and if there is a dural tear, you will be able to close it as like what you do in open. This is about pure and fluid. This is a busy slide. I'll just skip it. In pure endoscopy, you need water irrigation for clear view. This is again UB. UB is a less cost of instrument because if you are an arthroscopic surgeon, you have a shaver, you have a endoscope. But only thing is the RF. I appreciate about UB is the end plate preparation under direct vision. That is one of the important thing. And anybody who wants to go for fixation, this is one of the best thing about UB. You are preparing the end plate under vision. That is one of the best thing. This is about the nomenclature, pure and other things. I have not understood that paper at all. Versatility of the technique. If you want to have multiple techniques for multiple pathologies, that's good. But with our distant view technique, you will be able to use it for anything. This is an anterior cervical with distant view. In distant view system, there are two endoscopes, 45 and 90 degree. I can use the same endoscope everywhere. Only in cervical, I have to use a 2 mm endoscope. So there are no multiple Kerrison punches. The same Kerrison punch of 45 and 90, I can use it for 500 cases. There is no recurring cost of the instrument. This is anterior cervical. Trans uncovertebral vertebral artery is here, and this is the extruded part of the disc. It is a disc preserving surgery. Once the extruded part of the disc is removed, the route is free from the vertebral artery to the dural sac. That's enough. We are not compromising the disc height also, and we are not removing the rest of the disc also. This is intradural tumor. This is a neurofibroma. That's why endoscope is a tool. How you want to use it for various pathologies you have to learn. This is a stray suture, and we will use anasto clips, which are used in cardiothoracic surgery for closing the arterial walls. And this is quite fast. Nowadays, Medtronics is also having these clips, but they are 3.3 mm. This is just like a stapler, watertight. Patient can be mobilized after surgery after 2 to 4 hours. That's it. So learning curve, every technique has its own learning curve. This is what I advise to the, you have to go inside the OT and see the technique from skin to skin. If you want to try that technique after having the exposure to the workshop. Inside the OT, you have to learn small basic things. So intraoperative training is quite important. These are the two complications we have, nerve injury or the dural tear. So you have to know in wet technique or dry technique how to use that particular thing to close the dura. So attend courses, study the anatomy. Endoscopic anatomy is the same as the open, but you have to have that focus on it. If possible, try on animal model, visit the experienced surgeon currently performing that particular technique. If possible, perform first few cases in presence of him in your OT. If you are master, then try to modify the technique. You be again this. So our final goal is unreachable goal is 100% success, which is nobody is going to get it. But our reachable goal is everyday learning, training, and improvement. So any technique, try the base, learn the basics of it, the cost of it, economics of it, and then start doing it. Thank you.
Thank you, Dr. Vedas, for those words of wisdom. I think everybody is hungry.
Yeah, no problem.